Welcome to yet another wonderful program by the Nigerian Association of Nigerian Physicians, Delaware, Pennsylvania chapter. My name is Dr. Kelechi Lawrence. I am the social secretary, and today I'm going to be helping at least to anchor this program. So we are about to get started. It's wonderful that you woke up early this morning and you decided to come and be with us. Today, the topic we're bringing to you has to do with the eyes. The eyes. I'm sure you think and know that the eyes are important. If you can see things, it takes away a lot from you. Okay? And so we are very proud of our eye doctors who are going to be speaking to us about the various issues relating to the eyes and how to care about your eyes, right? You gotta care about your eyes so you can see things. Okay. So we're going to get going. Before we do that, just a few housekeeping things. If you want to use the restroom, you step out, make a left, right? Okay. If you want breakfast, of course, people can just get food as they come in. Make sure we have your information. There is a sign-in sheet. It's over here. When it's done, we want to put it over here. Okay. There is a sign-in sheet. So with that, we're going to get going. But before we do, and part of the reason why we gather at occasions like this is to know each other, right? Find out who is in the room and who we are talking to and stuff like that, just in case, okay? So what we're going to do is I'm going to introduce our fearless chairwoman who is going to come and, I guess, formally kick this thing off. And then we're going to do very brief introductions. There are not a lot of people here. I know some are physicians, some are non-physicians, allied health and stuff. But it's a good idea for us to know who is in the room so that, okay? All right, so let's give a warm welcome to Dr. Cordelia Udo. Dr. Udo.
Thank you. And thank you for leaving everything you scheduled to do today to come and be with us. Thank you. Especially if I look around, I see my family, my larger family at work. Yeah. So I appreciate you all. I'm Dr. Cordelia Udo, an eye physician and surgeon, the chair of ANPA, PA, Delaware. I'm going to be introducing our founder, so he can tell us a little about ANPA. The person I'm about to introduce is the founding chapter chair. He has worked closely with the chapter since April 2016. He is a results-driven and accomplished physician scientist in the pharmaceutical biotech industry. He has over 20 years of clinical research, pharmaceutical, drug development, regulatory experience, and submissions that span multiple therapeutic areas. He has held leadership and executive positions in several pharma biotech industries, including Abbott Laboratory, AstraZeneca, Omeros Corporation as VP of Clinical Development, Sanofi Genzyme, and BMS. He has academic affiliation with Drexel University as Professor of Medicine and Pharmacology. He has served on the Pharmaceutical Sciences Advisory Committee of the Food and Drug Administration, Editorial Board of Clinical Pharmacology and Therapeutics, and Board of Regents of the American College of Clinical Pharmacology and Therapeutics. He is an academician academic physician scientist. He has received over 8 million in research funding from the US government. He has delivered lectures all over the world and authored over 50 scientific publications. He had one of the highest scores in the country in the internal medicine and clinical pharmacology board exams. You can trust Nigerians. He obtained his MD degree with distinction and prizes from the University of Lagos. He completed his PhD in pharmacology from the University of London. He's a wild guy, England, in record time. He's a pioneer in the field of pharmacogenomics. He volunteered at Ground Zero in New York to take care of COVID-19 patients prior to the development of the vaccine. He speaks 4 languages, works out every day, and enjoys traveling. Ladies and gentlemen, it's only one and only Dr. Timi Ekedi. Edeke. Dr. Timi Edeke.
Thank you very much. Can you hear me?
Yes.
Yeah. I almost did not know who she was talking about. But thank you for the introduction. Let me join her in welcoming all of you here this morning. Your presence is very much appreciated. And we thank you for supporting the program, supporting this event, and for supporting ANPA. It's because of our interest, not only in eye diseases, but also in healthcare delivery in the US and for humanity in general. ANPA stands for Association of Nigerian Physicians in the Americas. Although that term is used, we are open to any person who is interested in healthcare. Some of the main objectives of this organization is to improve healthcare delivery and healthcare in general, not only in the US, but especially in the developed world and Nigeria, focusing on Nigeria. And in that respect, a lot of things has been done. Almost annually, there's health medical missions that takes place to different parts of Nigeria, meeting the health needs of the underserved. And several chapters also have medical and clinical outreaches in different parts of the United States. When we had the earthquake in Haiti, ANPA was involved in volunteering and in donating and contributing to that relief efforts. And ANPA is also involved in high-level discussions with the Ministry of Education, Ministry of Health in Nigeria, to look for appropriate ways of streamlining and improving healthcare delivery and medical education in the country. The chapter, which we call Delaware Valley Chapter or the Delaware, Pennsylvania Chapter, we have people from the tri-state area, Delaware, Pennsylvania, New Jersey, and also some people from Maryland as well, and anybody who is welcome. This chapter was founded in April of 2016 in Philadelphia, and we've been growing since then. we have this symposium. We've had several. This is our third one, I believe. We had one on kidney disease, one on sickle cell, and this is the third one. We have it biannually. And we welcome you to join us in that program. During the COVID pandemic, we had programs for churches and different communities in giving things to people who were in need at that time. We've also had health education outreaches in a church in Pennsylvania, and many other things that we have planned. We want to encourage you, if you are not a member, to feel free to join us. You are welcome, irrespective of your degree, professional affiliation, or your inclinations. We need you to join us in improving healthcare for humanity in the US and all over the world. If you have any questions, please feel free to contact me. My name is Timi Edeki, and I'm sitting somewhere up here. Thank you very much. And you are very welcome.
Okay, thank you, Dr. Edeki, certainly for helping to set the tone for today. This ANPA chapter, as well as
can be close to each other,
as well as the national organization, not only advocates for quality healthcare delivery to people who live in the United States, but especially in Nigeria as well. So that was a very important point for people to know, so that what we're doing here is not just for us, but we also have interests, especially back in Nigeria. So we're going to now, excuse me, advance into the main series of talks that we're going to have this morning. But before we do that, we need to get a sense of who is in the room. There's not a lot of people. I know other people are coming, but we'll just do very quick introductions. You tell us who you are and your area, if you are in medicine, even if you're not. I'm sure the speakers would like to know who they are talking to so that they know how to slant, how to position their message to make sure that it lands correctly. Okay, so I'm going to start. I'm Dr. Kelechi Lawrence. I'm not a real doctor. I'm just an ordinary PhD in molecular pharmacology. And I am the social secretary or something for this particular chapter. Okay, so we'll go to you and I'll bring this over there now.
Good morning. I'm Adora Yumoweni. I'm a physician, geriatric hospice palliative care physician. Thank you.
Good morning, my name is Bashir Sek. I'm from Senegal. I'm just visiting, but I'm a conference interpreter, French into English and international relation consultant. Thank you.
Thank you. That's actually my partner from Senegal. He's here for a program that we have next week in Wilmington, Delaware.
Good morning, everybody, and welcome. My name is Osamu Idahosa. I'm a critical care medicine physician. I work in St. Luke's Hospital in Bethlehem. I'm the vice chair of ANPA, Pennsylvania, Delaware.
Okay.
Good morning, everybody. My name is Okemte Omoru. I have a medical degree from the University of Lagos, and I currently work as a data analyst at the Children's Hospital of Philadelphia. Thank you.
Yeah. You know that guy?
Hi, I'm the daughter of Mrs. Teresa Eduardo. I'm Valerie Eduardo, and I'm a former president of the YWCA of Philadelphia.
Good morning. My name is Calvin Fountain. I'm a patient of Dr. Huda.
Good morning. I'm Everett Jacobs. I'm a 37-year retiree of AT&T, electrical engineer. proud husband of Dr. Jacobs, who will be speaking later. How you doing that evening?
Good morning. I'm Todd Culver, and I'm not a physician, but I play one on television. No, I kid. I'm an allied healthcare, hearing healthcare specialist in Dr. Udo's medical practice.
Thank you.
Good morning. My name is Carol Spells. I'm a patient of Dr. Udo and a retired school teacher concerned about our children's eyes. Morning. My name is Rita Cole. My patient, cataract patient. Cataract surgery coming.
Dr. Udo told us that she was going to bring some patients, and I think you can see some of those.
Good morning, everyone. My name is Duche Eze. I am based here in New Jersey, and I'm an accountant by profession, and also work with the New Jersey Department of Disabilities. Thank you.
Good morning, good morning. My name is Ngozi Okafor. I am a psychiatric and mental health nurse practitioner. Thank you. I based in New Jersey.
Thank you. So you're going to get introduced next. Would you mind? Thank you.
Next speaker, Jenny. That's my sister. I mean, when I say sister in residency, if you see me, you will see Jennifer. Whether it's in the academy meetings, any lectures, anywhere we go together, we study together. And when Dr. Pico, due to engagement, couldn't, it took few days, I know exactly who to call. Okay. And Jennifer said, "Nothing, give me time. I'm gonna get through this." And the husband drove her from Virginia. And so let me tell you more about Jennifer. Dr. Jennifer Jacobs is a board-certified eye physician and surgeon who did a fellowship in cornea and external disease at the University of Maryland, where she also taught as associate professor. She has been in private practice for 23 years in Manassas, Virginia. She also serves as medical director at the Notal Vision Monitoring Center in Manassas, which she has done since 2017. She has published work in the field of cornea and on horn monitoring for macular degeneration. Ladies and gentlemen, I introduce my other sister, Dr.
Thank you so much, Dr. Udo Cordelia. It's a pleasure. I'm glad you asked me to speak this morning. I'd like to thank Dr. Udo and also all of you for lending your ear this morning to hear this talk on dry eye. As Dr. Udo said, I did do a fellowship at University of Maryland. I did my residency at Howard University Hospital, and we've had many sessions together of learning ophthalmology. So I'd like to thank you again. And this morning, I'd like to speak with you on dry eye, the topic of dry eye disease. It is a vast topic, lots of material, but hopefully I've condensed it into, I've narrowed it really to fit into the allotted time, and hopefully you can get some important points and from the talk that will help you in managing your patients, and also for patients, things that maybe you can do if you have dry eye or know someone with dry eye. see if I can get this. Okay. I have no disclosures regarding this talk. So dry eye, what is it? Let's look at the definition of dry eye. So the Tear, Film, and Ocular Surface Society published a report from the Dry Eye Workshop in 2017, and they came up with a pretty comprehensive diagnosis or a comprehensive definition of dry eye. And it is a multifactorial disease of the ocular surface characterized by loss of homeostasis of the tear film. So the tear film isn't working as well, and it's accompanied by ocular symptoms. There are several etiologies that we see with dry eyes, and that's that the tear film is unstable. Also, there's hyperosmolarity, so there's more, it's more concentrated with salt content. You know, your tears are salty. You get a more concentrated tear. And there's ocular surface inflammation and damage, and also there are some neurosensory abnormalities that may play a role. So currently, there's anywhere between 16 to 50 million Americans who have dry eye, and there are hundreds of millions in the world that have dry eye. So it's a pretty big problem, and it is a leading cause of patient visits to eye care practitioners. The average annual cost is about $55.4 billion in terms of management of dry eye. So it costs society quite a bit, $55.4 billion to manage. But not only is it a burden to society, it's also a considerable burden to patients, because they're the ones who are having the symptoms and who are experiencing discomfort. So here are two cases that I'd like to go over with you. The first is a 33-year-old female. She works for an accounting firm. She's looking at the computer all day. She's looking at spreadsheets, and her eyes are stinging all the time. Stinging, and it always feels like, she says, "Doctor, it always feels like I have something in my eye. It feels like a lash all the time." And that interferes with her being able to complete her work on time. Her eyes are chronically red, and she says, "You know, I'm afraid my boss thinks that I'm drinking every night." And she comes in with red eyes. And so she is concerned. The second is a 54-year-old man who works outside as an elementary school teacher. He's also a coach, and he has teary eyes that seem to get worse when it's windy outside, and he complains that, you know, it interferes with his work, it's embarrassing, and the parents of these kids that he's coaching are saying, you know, "Why is he crying when he looks at my kid?" So it's a little embarrassing for him. So it affects the patient. Dry eyes is a significant condition. It interferes with their activities of daily living. It affects their productivity at work. And in fact, one study found that dry eye disease caused a 30% impairment in workplace performance. So it is a significant problem that we need to think about. It can reduce the overall quality of life for these patients. So now that we know that dry eyes is the tear film, there's a problem with the tear film. Let's take a look at the tears and see what the tears are made of. So basically, there are three layers that make up the tear film. The outermost layer, as you see here, the oily layer, is the outermost layer of the tear film. And it is very important in the stability of the tears. It prevents the tears from evaporating too quickly off the surface of the eye. So it comes from the meibomian glands. We don't have a picture, but those, you can see it, it's actually, the meibomian glands in the lids. And we have about 20 to 30 in the lower lid and about 30 to 40 in the upper lid. And so that is where our oily component of the tears come from, which help the tears to stay on the surface longer and not evaporate so quickly. The second layer is the aqueous layer. This is the watery layer of the tears, and it comes from the lacrimal gland that you see there, which is right underneath the lid in the lateral portion of the lid. And this is the watery layer that kind of cleans the surface of the eye. It's basically where we have a lot of anti-inflammatory mediators, a lot of also it protects the eye from infections. We have immunoglobulins in the tears, and it also has electrolytes, so we have proper osmolarity of the tears. So it plays an important role, and there are certain conditions like sarcoidosis, infections, things that can affect the lacrimal gland, where this lacrimal gland isn't working quite as well. Sjogren's syndrome is another big one, and we will speak about that a little bit later. The layer that's closest to the eye is the mucin layer or mucus layer. This layer comes from the goblet cells, which is in the lining of the eye, in the conjunctiva. And so the mucin layer is important for getting those tears to stick to the surface of the eye. Without the mucin layer, those tears would just fall right off the surface of the eye. So it helps the tears to spread evenly over the eye, and it helps the tears to stay on the eye. Now, there are two main categories of dry eye, and those are aqueous deficient dry eye, and we have evaporative dry eye. And the aqueous deficient dry eye means that we're just not producing enough of that aqueous layer. So the lacrimal gland may not be working quite as well. So the overall volume of the tears decreases. There's increase in the concentration of the tears, or what we call osmolarity. And evaporative dry eyes, the oily layer, which we see coming from the meibomian glands in the lids, they are affected, and they're not working quite as well. Now, most patients will have both components, aqueous and also evaporative dry eye. So this is a little bit the pathogenesis, which is a bit, pathogenesis is a bit complex, but this is a simplified chart, pretty much to kind of explain a little bit of what happens. There's the tear deficient, patients who have tear deficient dry eye, can have increased osmolarity, as we spoke about, increased concentration of the tears, which leads to inflammation on the surface of the eye. That in turn leads to damage to the epithelial cells, which are the outermost layer of the cornea. And there can be damage to those cells. Then you have more inflammation that's produced. And you also get an unstable tear film from that. Now, with evaporative dry eye, the same thing. You can have increased concentration of those tears, increased osmolarity. Unstable tear film, again, damage to the ocular surface. So it's kind of a vicious cycle. It just keeps going until we can break that cycle. So the ocular surface, which is the cornea, the front part, and the conjunctiva, the lining over the white part of the eye, the meibomian glands, which are in the lids, and the main lacrimal gland, which is underneath the lid, they all kind of work together to form sort of a functional unit. And you can have any one of those areas that are not working properly where patients can have dry eyes. So about only 10% of the cases of dry eye are from aqueous deficiency, and most 80% have an evaporative dry eye component. So who's at risk of getting dry eyes? So dry eye can affect anyone, any age, any race, any gender. And it's not so common in the pediatric. I know there's someone who works in pediatric field. It's not so common in the pediatric population, but it can be seen in some congenital conditions, also some autoimmune conditions in kids. Kids who have JRA, or kids who have Sjogren's syndrome, which is, we'll speak about a little bit later. JRA is juvenile rheumatoid arthritis. Also conditions like rosacea. We'll speak about that a little bit later too. Kids sometimes will end up with eye findings before they end up with any other findings for rosacea, which affects the lids and can affect the face. And we'll talk about that shortly. Also, Stevens-Johnson syndrome. When kids have that, I'll also speak on that in a bit. A small number of studies also found that the prevalence in kids is increasing because of all of the electronic devices and things that we're using this day and age. And ever since COVID, we're seeing more dry eyes in kids because they're using computers a lot, they're using their phones a lot, they're using electronic devices a lot. And a lot of times schools are, they're using computers at school as well. There's also, so in terms of who's at risk, older age. We tend to produce less tears as we get older. And so patients who are of older age, they tend to get dry eyes. They're at risk of getting it, especially females. Females who are postmenopausal have the biggest risk probably of getting dry eyes in the population. Who else is at risk? Well, patients that Cordelia and I and eye care practitioners see in their office who are on glaucoma medications. And in our population, glaucoma is pretty prevalent. And so sometimes patients are on 2 or 3 medications, and they are at risk for getting dry eyes, especially if they have BAK, which is preservative in the dry eyes. So in those patients, we might want to switch them to a preservative-free drop. But they certainly can be at risk of getting dry eye. Also, systemic, inflammatory, and autoimmune conditions that we spoke about, like rheumatoid arthritis, Sjogren's syndrome, lupus, patients who have lupus. So any autoimmune condition, thyroid conditions, any inflammatory condition can lead to dry eyes. Sleep disorders, because those patients many times are on a CPAP machine. And so I do see patients who come in my office, and after we go through the history, I find out they've been using a CPAP machine at night because they say, I wake up, my eyes are red, my eyes are gritty, I can't see as well. And sometimes with the mask, the air kind of seeps from the mask and affects the eyes. Now, in those patients, I might tell them to use an ointment at night. Nowadays, I know there are other CPAP devices where there are prongs, which may not release air quite as much, prongs that go into the nasal passages, but that is something that we see in our office. Also, patients who are on systemic medications, things like beta blockers, antihistamines, antidepressants, diuretics. Those are things that can also lead to some dryness of the eyes. And we mentioned computer use. We're all using computers quite a bit these days. I usually tell my patients, remember the 20-20 rule. That is, after doing work for 20 minutes, take a break from near vision, look out in the distance, blinking for 20 seconds, and then close your eyes for 20 seconds. And it does two things. It gives their eyes a break from such close work so they don't get so tired and fatigued. They look out in the distance, and then when they close their eyes, they're lubricating their eyes. So that oftentimes will help patients. Hormone replacement therapy is another one, especially patients who are receiving estrogen alone. The androgens help the secretion of the lacrimal gland. So if they're receiving estrogen alone, they can end up with dry eyes as well. And rosacea is another one, which is probably a couple of slides after, but that's a condition that can lead to dry eyes and can affect the meibomian glands, which are those glands that I showed you in the lids. And contact lens wear. The cornea receives oxygen from the air, and contact lenses can partially block this from entering the eye. So also poorly fit contact lenses can kind of damage that ocular surface, and the tear film becomes unstable. So all of those things can occur with contact lens wear. So I tell my patients, take your contact lenses out at night, give your eyes a break. There are some extended wear contact lenses, but I still tell those patients, take them out at night, give your eyes a break, because also sleeping in your contact lenses increases the risk of infection 8-fold. So we are very adamant about taking those contacts out. So what are some environmental factors that play a part? Well, there are quite a few. One is dry environments where there's not a lot of humidity. Now that's a pretty dry environment there. That's a desert picture, but there are lots of places where the humidity is low. On airplanes, patients, I have an airline stewardess who comes in and she has dry eyes because she's always on the plane and the air is pretty dry there. Also in hotel rooms, sometimes there's less humidity there. So I have patients bring their artificial tears if they are traveling. Fans, overhead fans. Patients should not be sleeping with overhead fans if they have dry eyes. Because again, when we're sleeping, our eyes become relaxed, and sometimes the lids might open up a little bit. And so what happens is the eye becomes very dry and they wake up again with some dryness. So they're starting the day off with a dry eye. As they go through the day, they're trying to catch up, trying to lubricate the eye. So they're already starting with dry eyes when they sleep with overhead fans. And that includes a fan in the car. You want to turn that fan away from your face, not direct it directly at you, especially if you have dry eyes. Smoking, it can be, patients who smoke, I recommend they find a smoking cessation program, not just for dry eyes, but certainly for dry eyes as well. Secondhand smoke can do it. Patients who are a smoker can irritate the eyes, and patients can end up with symptoms of dry eye. So rosacea. Rosacea is an acneiform condition in which there can be, it's a chronic inflammatory condition that affects kind of the central part of that face. We call it central facial and the periocular regions. It is more common in women, but can occur in men as well. And they can have these sebaceous glands that become enlarged, and that is shown there, what we call rhinophyma. There. So So those are sebaceous glands that have become enlarged, and we often see this in rosacea patients. So when a patient comes in to see me, I can tell already, you know, not every patient has this who has rosacea, but certainly if you see that, you know, okay, rosacea is playing a part here. These patients have elevated inflammatory mediators in the tears. And also when we look at their lids under the slit lamp, which is how we examine patients, if you look at that bottom picture, you can see where the glands exit the eye. So the glands are in the lids and they exit at the openings there. When we're looking at someone who does not have rosacea, we can see that's clear there. We can see the openings, but it's clear, and if I press on it, they're clear secretions. Here you can see the little whitening or capping of the meibomian glands, which these patients can get. When I press on their glands, I might get something like toothpaste, thick, like toothpaste coming out. So, you know, that's a sign, and you can imagine with thick secretions, that's not going to help them to see better. It's not going to lubricate the eye as well. They have abnormally turbid secretions plugging the glands. They can also get corneal changes. We call that punctate keratitis, which is areas where the epithelium is damaged. They can get vessels on the cornea, neovascularization, and they can even get ulcerations. They can get these non-ulcerated lesions, which the staph marginal infiltrates is what we call them. Those are lesions that you might see at the edge of the cornea. And yeah, so they can get multiple of those. Those are patients we want to see in our office because we need to treat those patients, and we use steroids. Oftentimes a combination steroid antibiotic to treat that. So we like to follow those patients because, as you know, with steroids, there are risks that are associated with it. Sometimes there's elevated pressure in the eye, or it can increase cataract formation, but in general, we use them a lot, and in most patients, they don't have that problem, but it's something we need to follow them as eye care practitioners to make sure if anything occurs, we can address it. They can even get ulcerations of the cornea. So this is a condition that we certainly would like to see. The other condition that I mentioned, autoimmune condition, is Sjogren's syndrome. These patients are the patients that have aqueous deficient dry eye. So their lacrimal glands is not working as well. They can get lymphocytic infiltration of the lacrimal and the salivary glands, and they can have compromised gland function. So that's why when they get this infiltration in the lacrimal gland, also the salivary glands, they can have dry eye and dry mouth. And that kind of keys us into Sjogren's syndrome. So we oftentimes will follow these patients with a rheumatologist or with an internal medicine doctor. It is a connective, they can have connective tissue problems, joint problems, and we can test for this with antibodies. They are at risk, some of them, for lymphoma, although the risk is not as high as we thought in the past. Okay, thyroid eye disease. So this is a patient actually with thyroid orbitopathy or thyroid ophthalmopathy. They have thyroid eye disease. So you can kind of spot this one from afar. You can spot that this patient has thyroid disease. Even patients who do not have proptosis, as you see here with the eyes sticking out further from the orbit, patients who don't have the lid retraction with the lids pulled back, that even patients who, when you look at them, you can't tell they have thyroid disease, they can also have dry eyes. So one thing is that it's not always correlated with serum thyroid levels. It can progress even if the thyroid levels are normal. So these are patients we also like to see in our office to follow them. They can have corneal exposure because their globe is sitting farther out from the lids or from the orbit. They can have conjunctival injection. The white part of the eye can become red and injected as well. And they can also have the optic nerve being affected from all those muscles around the eye being inflamed. Stevens-Johnson syndrome is another one. This is, I put this in because this is one where we want very early referral, quick referral. Because these are patients that it's a rare skin disorder or a rare disorder. It affects the skin, it affects the mucous membranes of the mouth, genitals, the eyes. And these patients can kind of have a flu-like symptoms. And on the skin, they can get these blistery blisters. So this is usually a reaction to infection. It can be infection, it can be medications. But these are patients we need very early referral because we can kind of preserve that eye if we can get an amniotic membrane on that eye, which is something the ophthalmologists, the eye care practitioners can do. Because what happens is they can get adhesions because the eye is so dry, they can get adhesions, and you can see that bottom picture, the eye looks pretty dry in that picture. So these are patients when we want to treat them early to make sure that we can preserve the eye. The amniotic membrane has a lot of, it's where we get that from different companies that can cryopreserve it. They can get that membrane to us, and we can place that on the eye and save the eye until the eye can recuperate. Other associated conditions, I won't go through all of these, but these are some other conditions. Allergies, those patients can have more, can have compromised surface, dermatologic conditions, head and neck surgery that may affect the fifth nerve, which is how we can feel on the surface of the cornea. And all of these, also vitamin A deficiency. Patients who've had gastric bypass surgery may have problems with absorption of the fat-soluble vitamins. So they can sometimes have dry eyes from that. Reduced blink rate. So the average blink rate is anywhere from 15 to 20 times a minute. So we say every 3 to 4 seconds we're blinking, but there are certain times when maybe we're not blinking quite as much. If we're using electronic devices, playing on games, our patients who are looking at Kindles, reading books on the computer, watching a good show on television, their blink rate is decreased. And if when we're watching a good movie, we're not blinking quite as much. Also, Parkinson's disease, as Muhammad Ali had, has Parkinson's disease. Those patients have a reduced blink rate. Bell's palsy, sometimes they can't close their eye all the way, but they also have a slowed blink rate. So these are all things that can lead to dry eyes. So I have a little demonstration. I'd like you all to hold up your hand, and when I say now, I want you to blink your eyes once, and then hold your eyes open as long as you can. When you have to blink, I'd like you to put your hand down and then look at that slide again. All right, so we're gonna hold up our hand. I'm gonna count to 3, and we're gonna blink and hold our eyes open as long as we can. 1, 2, 3. Keep them open as long as you can. When you have to blink, you can put your hand down, but keep them open as long as you can. As long as you can. Whoa, okay. I'm thinking that was pretty long for you. So some of you may have experienced some of these symptoms: tearing, burning and stinging that make you put that hand down. So these are that gives you a little bit of the idea of especially the moderate to severe dry eye patients. This is what they're feeling throughout the day. They're feeling some tearing, they're feeling burning and stinging, maybe sensitivity to light, gritty sensation, mild itching. If it's a lot of itching, we're thinking allergic conjunctivitis, but mild itching they can have blurry vision, They can not have contact lens intolerance, redness, and they can feel like they need to blink all the time because they're trying to lubricate their eyes. And those patients who have dry eyes tend to have symptoms that progress as the day goes on because you have evaporation just from normal everyday having the eyes open and using the eyes. So those are the symptoms that we might experience. So diagnosis. We do a thorough history, of course, see if they have any of those risk factors that I talked about, look at their symptoms, look at their blink rate, see if they're blinking. Some patients blink partially and they don't blink all the way and their eyes are drying out from that. And we, of course, we check the vision. If the vision's decreased, then they're affected significantly by dry eyes. And then we do a slit lamp exam, and that's a picture of a slit lamp at the top. We do that exam where we can examine the meibomian glands and we can see if those glands have thick secretions or if they're more liquid. If you have enough meibomian glands in the tears or in the lids, because sometimes those glands become so affected they drop out and they don't work anymore. We can check corneal sensation because there's that loop, you know, when our eyes get so dry, we have a lot of nerves on nerve endings in the cornea. It'll send a message to the brain to produce more tears and they get a flood of tears. So those patients may come in complaining of tearing. You know, all of a sudden I get this tearing like the case that we saw, that we spoke about earlier. Also, we can look at the height of the tears and if the tears are breaking up quickly. And we can do this test on the left. It's called the Schirmer's test, where you see the little strips there. That is a test that can kind of tell us if the patients are producing tears and how much. We can measure the amount of tears that they're producing with that little strip. And we can look at face tears. We can look at reflex tears by doing the Schirmer test. A big thing we do is surface dyes using fluorescein dye. That's when you go into your doctor's office, they put that little yellow solution in the eye and we look with the blue light. And that can tell us how the surface of the eye looks. If the surface has rough areas like you see on the top right, we call that punctate keratitis. So you can imagine instead of looking through clear glass, it's almost like looking through frosted glass, you know, if you have enough changes like this. But we can see mild, moderate, severe changes in dry eye patients. Also, we can do the green dye called lissamine green, which stains the conjunctiva, cells that have been damaged in the conjunctiva. And usually we can see if the eyes are affecting it enough. And we can also look at the concentration of the tears, the osmolarity of the tears. And we can also confirm inflammation with a test that we call matrix metalloproteinase 9, which is just a test that confirms inflammation on the surface of the eye. Treatment. So these are some treatments that patients can do, oftentimes some of them on their own. We like to educate the patient about their condition because an educated patient is a patient who's usually going to be much more compliant because they understand their condition. And so we like to educate the patient on dry eyes. We can modify environments, the fans. We can, I can have a patient go out and buy a humidifier to put in their room so they have humidity in the air. We can identify potential medications, and with systemic medications, we might work with their primary care in terms of maybe switching or decreasing a certain medication that may cause dry eyes. And topical medications, we try to use preservative-free. And I oftentimes will have patients, if they're using artificial tears 4 times a day or less, they can use the bottle ones. If they're using it more than 4 times a day, I usually recommend preservative-free tears because they don't have to worry about the preservative irritating the surface, using it multiple times. Warm compresses are something patients can do. You can get this over the counter. Amazon sells it. It can be Bruder mask. It can be other mask like the one on the left lower. or they can use a warm, wet towel. And we recommend patients use it for 15 minutes every night, and that helps those meibomian glands work a little bit better. And if you think of butter, you put something warm over it, becomes more liquid. We're trying to make those glands work better and become more liquid. And these things you can buy over the counter. These are some lid wipes. I know some patients have used tearless baby shampoo. I usually like the wipes because there is a derivative of formaldehyde in the tearless baby shampoo. It's not formaldehyde, but I think this works a little bit better, any of these, for treatment of the meibomian glands. Other treatments, ocular lubricants. Those are the artificial tears, the gels that you get over the counter, overnight ointments. These are things that if you're waking up feeling gritty and sandy, overnight ointments can oftentimes help. Patients who are pretty dry, even with that, sometimes I recommend these moisture chamber goggles. These are goggles that go all the way around. They either have foam or plastic, and that will keep the moisture in. They don't have the wind bothering their eyes as much. So that works well. Wraparound sunglasses, omega-3 fatty acid or flaxseed oil supplements. Those oftentimes will help. The studies vary on that, but I find in my practice, it really makes a difference when patients take the omega-3 fatty acids. So I always ask them, make sure it's okay with their primary care. And then I think, you can go ahead and take that because it does work pretty well. Adequate water intake is very important as well. So when we treat patients in the office, oftentimes we have to use topical corticosteroids because we're decreasing inflammation on the surface of the eye. We use that only for a limited duration, maybe 2 weeks when we're starting a different medication on the patient as well. Oftentimes we use non-steroid topical drops, such as cyclosporin. It's a topical cyclosporin. You all may have heard the Restasis, seen the commercials for Restasis. That is a topical cyclosporin. Cequa, Vivi, those are all topical cyclosporins. Also, topical LFA1 antagonist, that's an inflammatory mediator, LFA1, which is lymphocyte functioning antigen. So it's an antagonist. Lifitegrast is the antagonist, decreases inflammation on the surface of the eye. You may have seen commercials for Xiidra. So that also works for dry eyes. We also have a newer drop called Mibo, and this one stays on the surface a little bit longer. It's lipophilic. It stays on the surface longer. So sometimes in patients, I'm trying artificial tears. I'm trying either one of the cyclosporins and maybe the Xiidra, and they're still not getting better. If they have meibomian glands in the lids that aren't working properly, I might have them try Mibo or perfluorohexyloctane. Then we have nasal sprays. If this nasal spray, it's the only one I think that we have, varenicline. Sometimes patients can use this spray, and in the office we might show them that where they're spraying, and they are, it's a cholinergic neuroactivation. They're activating the parasympathetic pathway. So they're spraying in the nasal area, and if they do it wrong, they're going to sneeze a lot. So we do it in the office so they know how to do it. And it works pretty well. I have some patients who love it because they don't have to put something on the surface of the eye. And then punctal plugs, that's a picture of a punctal plug on the lower left. This is something we do in the office. It takes a few minutes. We just plug that drainage system. If you look here, you can see the lacrimal duct. This is where our tears drain, and they drain into the nasal cavity, which is why when we cry, we have to blow our nose. So if we block one of those drainage systems, then their tears don't drain off the surface as quickly. And then we have, we can apply topical antibiotics to the lid margin because we can have a increased flora with meibomian gland disease. We can use oral antibiotics sometimes. Autologous serum drops. This is a big one for patients who have severe dry eyes. We can take their own serum. We send them to certain pharmacies may do it, compounding pharmacies. They draw their blood, spin it down, and they can get serum drops. And these drops are pretty expensive, so we don't use them all the time. But they do work quite well with all of the growth factors and anti-inflammatory properties in our serum. And it's their own serum, so they can use these drops, and that oftentimes will do the trick. And then we have therapeutic contact lenses like the one on the left where we can fill with fluid and that will bathe the surface of the eye all day. We can use amniotic membrane. It's almost like a contact as well that we can put on the surface of the eye, dried amniotic membrane, and we can use trachorrhaphy, which is where we partially close the lid so that they don't have as much exposed to the environment. So they only have and that one's pretty closed, but sometimes we can close it partially or we can do it with sutures. And then lastly, we have treatments we can do in the office. We can kind of clean the lid margins, exfoliation of the eyelids and the meibomian glands. We can use heat therapy to help those meibomian glands work better. Some work with gentle massage to get those glands to work better. And we can also use intense pulse light, which was fairly recently approved by the FDA for dry eyes. It's been used in dermatology for years, but patients who were getting skin treatments found that their eyes weren't quite as dry. So they did studies and found that it works quite well for dry eyes. Basically, it gets rid of those telangiectatic vessels that are bringing inflammation to the lid margin to the eyes, and also gets rid of some of those inflammatory mediators and decreases the flora on the lid. And with that, in summary, dry eyes affect a significant number of individuals in our society, decreasing their quality of life. It's multifactorial disease, and of course, it results in ocular surface damage. Now, the damage can be repaired when we can break that cycle. And there's tear film instability, inflammation. Patients also can begin some treatments on their own with artificial tears and all of the things we talked about that are over the counter. And then we really like you to refer those patients, the physicians in the room who have rosacea, who have other systemic diseases associated with dry eyes that we spoke about, who have decreased vision, they're just not getting better. And patients who've tried other treatments or treatments you've recommended, over-the-counter treatments, and they are still progressing, we like to see those patients as well. So I thank you for your attention.
Okay. So wonderful, wonderful, wonderful. This is probably the first eye talk that I've listened to. I see all these commercials on TV about eye products, and I'm like, why are there so many eye products? Now I have a better idea. I'm sure you guys have questions, right? Anybody have questions? Raise your hand. Thank you.
Thank you. That was such an awesome talk. So you did say a treatment for people with Stevens-Jones syndrome, but you didn't really explain it in the treatment.
Yes.
And I think that's my main question. The other question I had, you kind of answered it a little bit. I work in the intensive care unit, and we at times where patients are paralyzed and on ventilator and their eyes are open all the time, and you wonder how many times a day should you apply those drops? You know, so if you want to just touch.
Yes. So patients who are in intensive care, we actually recommend you use ointments because sometimes their eyes open up. Ointments will stay on the surface longer. 4 times a day is usually, but if it's if their eyes are red and in you know, just from exposure, sometimes I will recommend an antibiotic ointment, something like erythromycin ointment if they're not allergic to erythromycin. There's bacitracin ointment, cuts down on kind of the overgrowth of staph that maybe they may have. But you can always use something like a preservative-free ointment as well. I would say 4 times a day for patients who are in intensive care, or more if they need it. You see it's not staying on long enough, but usually 4 times a day, we'll do it. And you asked about Stevens-Johnson. Yes, we like to see those patients because they can get adhesions. We call that symblepharon, where the conjunctiva, that white, the lining over the white of the eye, can attach to the lid. And when that happens, of course, their eye won't move as well. They can get this dried surface. The cornea can become dried, damaged epithelial cells, damaged conjunctiva. They can lose vision. So what I do, I showed the second picture there is that's actually a picture of Procera, which is a contact lens with amniotic membrane. However, for Stevens-Johnson's patients, those patients, we can also get amniotic membrane that's not a contact. It's a whole layer of it. Those patients need that layer placed over the eye and wrapped around underneath the lids so that it provides a barrier. And those patients, because the amniotic membrane has such anti-inflammatory properties, such growth hormones to help heal the surface, it works quite well to keep those patients from getting super dry. And even over the amniotic membrane, you can use an ointment.
Cool.
I have a question about the changing of the weather.
Yes.
Does that affect, because I find that the winter months, my eyes are very dry.
Absolutely. It does. It can affect it. In the winter time, yes, that's when we find patients are getting drier eyes because there's less humidity. So it does make a difference. And I might recommend patients get a humidifier. Drink plenty of water, get a humidifier that's in your bedroom or in the room you spend most of your time in, or in both. And that helps a lot. You're welcome. And use artificial tears.
So my question is on the costs, the drops. I have patients who might use a drop they opened a year ago. So how common is infection with open drops, and what do you recommend?
So I haven't encountered personally infections with open drops. So a year is a long time. If it's preservative free, then you're even worried even more about them using drops. So I haven't encountered a lot of infections from that, but we don't like patients using it if it's a year old, especially if it's preservative free. But I would just recommend that they get, I know it's expensive. Sometimes I will give patient samples. But for primary care or someone who's in a different non-ophthalmology field, sometimes we find if we send it to a specialty pharmacy, they can get it cheaper. And there's GoodRx, there are other things that they can use. So I do have some specialty pharmacies sometimes that I will send, say, the medications that I prescribe for patients to, so that they can get it. They'll apply all the coupons, and usually the pharmaceutical reps will be able to tell you. If even for the artificial tear, sometimes they have programs where they can give patients reduced costs. Usually those are over the counter, so it might be a little harder, but prescription ones, they can certainly if you talk with the rep for like an Alcon or Allergan rep, Bausch & Lomb, they can kind of tell you what programs they have for patients who can't afford.
At times when I wake up, yes, one eye is shut.
Yes.
I don't force it open, so it takes a little while before it decides it wants to open up.
Okay.
So I just wanted to know what causes that and how can I alleviate it?
Yes. So it does sound like you may have dry eyes because if your lid is sticking to the surface of your eye, then your eyes are probably pretty dry. And so what happens is you're going throughout the day, your eyes are getting dry, your lid is over a dry surface, so it sits. We have some patients who even have recurrent erosions of the cornea. They have where their lid sticks and they wake up. It feels like they can't open their eyes, and they have pain when they wake up because those cells have stuck onto their lid. So we recommend an ointment, and that's over the counter. You can start with something like I usually stick with the big name companies. I know they do a lot of product quality care. So I would maybe try something like a Sustain Nighttime, Refresh PM. And those are ointments that work pretty well to lubricate the surface so that you don't have that sticking. A drop. You can use a drop. There's some drops that are thicker drops. Celluvisc is one that's a thicker drop that you might be able to use, or one of the gels, which is still in a tube. The gel is in a tube, but you can kind of drop that in too. That works well. Some patients prefer gels and not the thick ointment. When you're doing the ointment though, you'll put a pea-sized amount, pull the lid down and stick it in that lower lid, and then it'll lubricate things. A drop you can do. You can do a drop. It may work for you. So you can try something like a thicker drop and see, like Celluvisc or something.
My question is on risk. So for people who spend some time or kind of like a lot of time in the pool, especially chlorinated water, are they at risk of dry eye?
Anything that can interfere with the surface can do it. If they're getting irritation from the chlorine in the pool, sometimes we can see patients, we can see like the punctate staining that I showed you where, that dry eye patients can get. It's not considered a risk, but if their eyes are getting irritated from the chlorine, I would recommend they use goggles when they're in the pool. But no, it in particular is not going to, make them have dry eyes, as long as they're feeling okay after.
Thank you. I had another question. It was more of like a curiosity kind of question. Yeah. So about the punctate plug that you said was supposed to like stop the drainage. Mm-hmm. Do patients complain about like it being uncomfortable? Because I can imagine something being there in your eye.
So there are different types of punctal plugs. Some we can insert all the way in, and they're collagen plugs, and they will dissolve over time. I tend to not use that. I tend to use the silicone plugs, which, some of our intraocular lenses in cataract surgery are made out of silicone. So it's pretty well tolerated. It has a little cap like you saw on the picture that sits flush with the lid margin. So for the first week or two, patients might feel like something in the eye a little bit when they look a certain direction, especially if the plug is here and they're looking this way, they may feel it a little bit, but after a couple of weeks, usually they don't. Yeah, so it's pretty well tolerated. It has that cap. If they are complaining and tearing a lot, we can always grab that cap and pull it out, but I tell them, give it a good week or two, and most patients do quite well.
Okay. Wonderful, wonderful presentation. Let's give another round of.
Thank you very much.
Thank you. So now our next speaker is going to be our chapter chair. I'm going to invite Madame over there to come and introduce her. Okay, Ngozi Okafor is going to be introducing Dr. Udo.
Good morning, everyone. All right, so my name is Ngozi Okafor. I have the privilege to introduce Dr. Cordelia, fondly called Ezenwine. She's married to Dr. Chris Oda, and they are blessed with 3 children and 3 grandchildren. So her education. In 1981, she graduated from Temple University with BSc in pharmacy. In 1995, she also attended University of Pennsylvania, Perlman School of Medicine, and graduated with medical degree. Finally, she obtained her ophthalmology training at Georgetown University. Her professional career, she worked as a pharmacist for 10 good years. And since 1996, as an eye physician and a surgeon. She's a fellow of American Board of Ophthalmology, a president of Premier Vision, with offices at Willow Grove in Philadelphia, Pennsylvania. She is also a real estate holder and a manager at Willow Grove, Warrenton, Shelton, and all in Philadelphia, Pennsylvania. She's also a president of Premier Vision with offices at Willow Grove in Philadelphia, Pennsylvania. As a philanthropist, she is current president of NKO Foundation, a 501c public charity in the United States of America, and NKO Dynamic Foundation, an NGO based in Nigeria. She has completed so many projects through her philanthropic work. In 2017 to 2018, she completed Samuel Agobor Memorial Secondary School for St. Paul's Anglican Church in Ogidi, Nigeria. 2019 till current, she has an ongoing construction of a complex containing medical and surgical center, blind and deaf and vocational school in Ogidi, Nigeria. 2019 till current, she has an ongoing scholarship and assistance for business startup in Anambra State in Nigeria. Since 2023 till now, she completed 2 big bungalows for poor families at Ikenga, Ogidi in Nigeria. One still pending. 2018 till current, she's working on project on NKO Farms Limited in bureaucratic slow process with Anambra State and Ogidi landowners. This woman does not rest. She also finds time to engage in different community projects, which include Nigeria American Women for Youth Advancement, NAYA and NAYA USA, to provide scholarship for the young adults. She's also a chairwoman, community chairwoman of Free Medical Clinic for the Anglican migrant community. She's now the chair of ANPA, Philly, Delaware, and she is the matron of NAMNIA USA. Can we give a round of applause? Oh, thank you, my sister. These are my larger family at NAMNIA USA, where we are trying to help our children. I thank you for that introduction. We never know where life will take us. Just be ready and be courageous. Take the torch and run with it. And it happened with this talk. Alcon is supposed to be here giving a glaucoma talk. And a few days ago, I learned that it won't be possible for the lady, Dr. Ho, to come down. And so I told them, don't worry, I'll do it. And so, yeah, I am. And so let me start. And I manage a whole lot of this. I run through the slides and then I'll get away and talk about management, the way I do it. So glaucoma is a common eye disease caused by increased pressure in the eye that causes damage to the optic nerve. In the US,
glaucoma is responsible for 9 to 12% of all cases of blindness. Worldwide, an estimated 111.8 million people are likely to have glaucoma by 2040. Intraocular pressure is the only modifying risk factor. That's all we treat. But I was able to do this, change this before I started. Yeah, this is power. Is this courtesy of American Academy of Ophthalmology for most of the slides here. Glaucoma progression is
Hang on, you need to share the screen. Share the screen for the Zoom people to see right here. Share. Hang on. Yeah, share. Okay, where is it? Is that one? Yeah. Share. Okay, now they can see. The Zoom people can see.
Dan, can you see that? Can you see?
Well, yes, I can.
All right. So this is where we are now. Sorry for that.
That's okay.
So glaucoma progression, primary open angle glaucoma. It is asymptomatic in early stages, and often when they present with vision loss, that's when you know they have glaucoma. Well, let me not give examples. I'm wrong with this. It can result in blindness. These are the risk factors. African American heritage. Blindness is 3 to 4 times more common. People over 70, yes. People over 70 years of age, 10% prevalence as opposed to 2% in the Caucasian race. It occurs in early age and will present with advanced disease when they come in. A gentleman, a painter who someone hired and was keeping the wall until the lady said, go examine your eyes. He came in, he has to go on disability, glaucoma. So I'm gonna run here, but let me point this out actually. Age over 40 years, the risk factor is 2, African American versus Caucasian, relative risk is 4. Family history, 1st degree relative is 2 to 4 times. Myopia on the lower end, decrease cornea thickness, 3, because these people walk around with low pressure. In those days, we just, prior to laser vision correction, we didn't know that cornea thickness affected the pressure. And so when we started ablating those corneas and making it thin, we realized, oh, so someone will be walking around, they said, oh, my pressure is good. Did anybody check your cornea thickness? Continuing relative factor here. Again, the same thing we just mentioned. Risk factor analysis, level of glaucoma risk weighing score, high if the risk factor is 4 or greater, moderate 3, low 2 or less. Screening for glaucoma, we measure the IOP, we evaluate the optic nerve. I'm gonna show that and I'll go more into the anatomy of that optic nerve and visual field. Okay. Any one of this can make you, if any one of these items is abnormal, you are suspect for glaucoma to say disease, being a suspect for glaucoma. And the insurance pays as much as you come, it's not the vision. All right, recommended frequency of periodic eye exam. You guys can read this. Glaucoma suspect, let's go there, is normal visual field. Your vision will be normal. If it's abnormal, we already crossed the line. Open normal appearing angles plus elevated intraocular pressure and or abnormal optic disc appearance on nerve fiber layer. This is that's where the rubber meets the whatever, and that's where we get involved to evaluate your pressure, check to see what your cornea thickness is, and check your optic nerve. Okay, so this is a normal optic nerve. I usually call it the powerhouse in the house, in the eye, where things enter and exit to go to the brain. And if you look here, I'm gonna step out. Okay, so this is the ring of that optic nerve. This is all this thing area here. There are millions of electrical wire light structure that take the light impulse to the brain to be translated into image. When we start to lose that layer on a continuous basis, that's what glaucoma is. And when we do, you see the light area there that does not have it, it starts to get bigger and bigger. These are the vessels. The darker one takes blood away, the lighter one brings blood. So I've explained it. This is again, let's not go through this. These are for the for ophthalmologists. But if you can see here, okay, as we are looking, we start to gauge and see there's a thinning, elongation and some focal area of thinning. That's for us, the ophthalmologist. And usually they're asymmetric, okay? This like this is a suspect. Okay, one eye light area in the center we call the cup, being bigger, much bigger than the other one, at least by 2.5 times bigger, is considered a suspect for glaucoma. This is another asymmetric optic nerve. Okay, the one on the left-hand side, bigger. Here we go. It's working, you start wondering, where have you been all this time with such a big optic nerve? Sometimes if they're young people, it makes you cry. And as we are doing this, when we observe a thin hemorrhage, it's a sign to us that it's progressing, and that area will be thinned. The nerve fiber layer will thin out. So this is a normal field for us. You can see that now. Oh, where is the one for the? Okay, they didn't get it, but the one on nasal step, this is shaped like this. That slide is missing. Let's go. And this is the progression of visual field from the left to the right. That's why we take those visual fields, and then we'll correlate this finding with the OCT that analyzes the optic nerve. They have to be to be talking the same. Meaning if you see something temporal, we need to go nasal to the optic nerve and see it too. The goal of treatment is if I always say, if we can't cure glaucoma, it's not cataract. Okay, so if it's traveling at 50 miles an hour, we want to make it 5 or less to extend your vision for the rest of your life. And how aggressive we are depends on your age and the severity you presented with. So glaucoma medication decrease intraocular pressure by decreasing aqueous production or increasing outflow. So we go through them. This talk is really about the drops. So I'm just giving you a quick overview of glaucoma. But now let's talk about, here we have the beta blockers, the yellow top. In glaucoma, we go with yellow. I mean, we go with color of the top. That's the language we talk, okay? They are the beta blockers, okay? Forget about selective or non-selective, but you have the timolol, levobutanol, beta-gan. Timolol is the most popular of these. It almost causes the same problem. There are side effects, and they are used mostly twice a day. But there are formulations that they come in gel that you can use in the morning. Insurance, some insurance won't pay, but we'll talk about that when we get to compliance issues. So here, that's the side effects. Congestive heart failure, bronchospasm. Indeed, beta blockers they have killed people. You use it on someone with asthma, COPD, so depression, confusion, impotence, worsening of myasthenia gravis. And then we get to the topical adrenergic agonists. Okay, these are purple drops. The iopidine, the white top, is not really used anymore due to tachyphylaxis. These are language of pharmacists. But they're purple drops. The topical adrenergic agents, the most popular one we use is the brimonidine. Okay, and they come in combination, and we'll talk about that combination. There are side effects. Systemic, decreased blood pressure, drowsy, fatigue, dry mouth, ocular burning, or on putting your drop in your eyes. Conjunctival injection, pupillary dilatation, allergic or toxic reactions. Yeah, that's when we move. These are the topical cholinergic agonists, the green tops. Okay, I don't use this unless I'm trying to decrease laser peripheral iridectomy. They constrict the pupil for us. Or if someone is seeing glare in the areas, glare as well, that's not a talk here. So the topical cholinergic agonist. Okay. The short-acting is pilocarpine. That's the only one. The other ones are, they're phasing out. Just know that. Their side effects. It's mostly the reason they're phasing out. Systemic increased bronchial secretion, nausea, vomiting, diarrhea, apnea.
ocular increased myopia, eyebrow pain. You put it there, that waiting as how are you? I'm having headaches. Anything has to do with this medication, yes. Decreased vision. So now we come to the systemic carbonic anhydrase inhibitors. Okay. These ones are potent. They will decrease production of aqueous. And the most popular among them is the diamers, acetazolamide. The naptazine we also use. And then they are topical. We call them the orange tops. Dozolamide, which comes in combination with timolol, acincosol, the name, and Aesop. That's them here, the orange top. That's the combination, the blue top on the side. The carbonic anhydrate side effects, malaise, anorexia, depression, paresthesia, serum electrolytes, abnormality, renal calculi, blood disc. I mean, the patients are the ones that regulate these systemic ones. They'll come to you and tell you, I don't take it when I have to go out because it drives them to the, it causes, diuresis. They go to the bathroom a lot to pee. They have to take it with food, otherwise GI side effects. And these are mostly elderly patients, and they tell you, I don't use it at night, so I will sleep through the night and getting up, going to the bathroom, and these people can trip and fall. And so now we get to the prostaglandin analog, the green tops. Okay, outflow. That's where their power is. They cause redness in the eye. Iris pigmentation for those with hazel eye. Eyelash growth. One of them are commercial eyelash growth agent. Periocular skin pigmentation. This is usually the milder ones I go with first with my elderly patients. And if they're female, I tell them, and they can cause macular edema, cystoid, and history of uveitis, especially after cataract surgery. And so we come to the new ones, the rho kinase, ROCK inhibitors. Okay. They increase the aqueous humor outflow, thereby decreasing IOP. They have neuroprotection, and they can reduce scarring of blebs. For those of us who do trabeculectomy, this is medical we're talking about. So we have the repressor. That's what, and rocklatan. That's alchemy. Rocklatan is a combination. They remain white top. Their side effects, potential side effects include conjunctival hyperemia, red eye, really red eye. That's their limitation, including a hemorrhage. This is pinpoint redness as if little bleeding on the white part of the eye. Cornea vaticillata. I don't think Audrey is here, but that's one of my patients with that. I was shocked. And they said it will go away. Have you seen some of them? I said, I didn't even know. And so I said, gee. Anyway, corneal opacity allergies. And okay, now we get to the glaucoma medications in combination that promote compliance.
All right, so COSOP and Combigan. The COSOP contains the beta blocker and the this is not anhydrase inhibitor. Carbonic anhydrase inhibitor. Okay, that's the one, the pill, the orange top. So COSOP contains the blue top and the orange top. Combigan, the purple top and the yellow top. And the lime top, Zembrenzac, is a combination of the yellow top and the purple top. And then you have the white tops, Rocklatan, which contains the repressor and one of the green tops. So these are powerful combinations. And it could be, this is punctal occlusion. As we tell them, you put your drop in and you hold, just like we showed you where the punctum from the prior talk. You hold and pressing your nose for about 2 minutes to prevent some of these medications from going down and going to your throat. And it will bypass the first bypass from the kidney as if you're just giving them IV. And so, and if they are going to use another medication after that, is you wait 5 minutes. We're gonna get there. Patient compliance improved with patient education, informed participation in treatment. Glaucoma cannot be controlled, but cannot be cured and can be controlled, excuse me. Yeah. So I'm gonna step aside and talk about what I do. Okay, and so it's a burden for patients to use all these medications. Okay, so when someone presents with mild glaucoma, I do laser. We have selective laser trabeculoplasty as opposed to argon ALT laser trabeculoplasty. I have both machines. So the SLT, minimal changes in the angle and no scarring, little or none, I've not seen it. So, and the pressure lowering can be 6, even more, you know, depending on the pigmentation in that. And then I follow them. This pressure lowering can last up to 6 years. And when it goes up again, I treat. My own limit is 3 times. And when it stops working, I go to the drops. And so let's talk about someone who presents with, say, moderate to severe glaucoma, and you are there fighting to, depending on their age. You know, when old folks, I'm old too, but when our seniors present with glaucoma, you sort of watch and see, should I treat? What will I treat with? How long? Sometimes I tell them, how long more are you gonna live? Do we need to make you miserable by the drops and all of that? But young people, yeah. So I've given you the combinations. There are 2 blue tops and each one contains 2. So you either use one or the other. And then the one that's not common in that becomes number 3. And then you have the green top, okay? Or you can choose to get the white top, the Rocklatan that has the green and the repressor. So you have, now, 5 medications in combination. Without that combination, they'll be using 5. And the Lyme one is usually 3 times, depending on 2 or 3 times. If it's a severe glaucoma, it becomes 3. And so these people will wake up, put 1 drop, wait 5 minutes. If they need to do this, they do. Wait 5 minutes or 10 minutes. They usually will wait 10, okay? And then put the other one, and then wait again, and then put the other one, and then do the same thing. So it becomes a burden all their lives trying to do this. I mean, there are other options, surgical options, but that's not what this talk is all about. You know, and so some of them are here, my clients, to tell you just how they manage this, how big a burden it can be for them. So compliance is the biggest issue with this. So I believe I'm done with this slide, with this talk, glaucoma. So the next talk, I don't know if I need to get there and if I have the right slide. I mean, if my slide will show, I can move on right away to refractive cataract. But I don't know if anybody has a question on this.
Thank you, Dr. Uda. This is a very important topic for all of us, actually, because this is a disease of Black people. And, you know, a lot of us probably have family members that are afflicted with this. Quick thing, Rocklatan, Zalatan, and Travatan, is it the same group of medicine?
Yes.
Okay.
Yes, mean Rocklatan?
Yeah.
Yeah, Rocklatan has latanoprost.
Okay.
The prostaglandin analog, the green tops. Travatan, the green tops. Lumigan, the green tops. Okay, but the other medication within that is the ROC inhibitor, is the repressor.
Okay. Is it new in the market or this is first I'm hearing about? Just curious.
I think it's been there for maybe 2 or 3 years.
Okay. Okay.
Okay, and it's very powerful, that combination. It's just the side effects.
Okay.
Yeah.
And the other question is, I know you said this topic is mainly on drugs, but you know, we've been talking about glaucoma not being able to be cured for a long, long time. What is there research somewhere? I mean, is there an opportunity for transplant? Is there? I just recently saw in the news about Neuralinks with one of Elon Musk's companies. I don't know if you guys know about that. What are the new things out there, you know, for treatment of glaucoma? Or are there anything new out there? Thank you.
I'm not in the research arena. When they finish researching, they bring it to us and sell. So neuroprotectors. Yeah. Neuroprotectors. They should so that's my answer.
Okay. So I saw that people of African descent have a 4 to 5-fold risk likelihood of becoming blind or something. Is that just a socio-economic issue, or is there a genetic basis of it? Could probably come back to some of the research things. Do we know or have an idea of why that risk is so much higher?
Yeah, I didn't bring that slide of genes. I didn't know you guys would be interested. Yes, it is a genetic issue.
depending on whether it's a first degree relatives. So whenever you see, if your mother, your father, any one of them, or your siblings, you better check your eyes.
So thank you for this presentation, Dr. Udo. So what is the message to the lay public about screening for glaucoma? When should they start and how often should they be screened?
Actually, I do have that test. If you have a family history, I will recommend that someone screen early. Okay.
What's early? What's early?
What's early? In your 30s. At least if your optic nerve is big at that time, that's when it is necessary to record it. Do OCT, because you need to follow that. It's a progressive disease. Okay, and if even if they, you see them, well, they will disappear. I'll be honest with you. And then they will come back, either they've had something that scares them. 5 years later, they'll come back. So at least you have some something to check. Yeah. And depending on what you find, will you base your follow-up on that. And their history.
Thank you, Dr. Yu. I have, I guess, twofold questions. The first is about the drops. I'm one of your older patients, and I was diagnosed with glaucoma very early on. They started me with the drops. I guess my question starts with the drops. I was on Comagan. No, I think I started with Lumigan. Then I went to Comagan. And then it was like I was on Azoth for years. Then the Azoth, of course, started giving me problems. Number one, it would conglomerate, it would get into the corners of my eyes, and I would, constantly trying to wipe my eyes. Then it went to, I just started having numerous problems until I met you. And then you said, okay, we're going to change your drops. And you started me with the, we call it the yellow cat. I'm not sure of which one I'm on.
Beta blocker.
But it's working for me. It's working a lot better.
Yeah.
The other thing is, well, I guess you haven't gotten to that point.
I'm actually finished glaucoma, so if you, I'm transitioning to another.
Yeah, and it's fine, and I'm happy with the treatment.
Okay.
But my thing is, how long, or will I be on the yellow tops for?
Yes, for life.
For
Glaucoma is a lifelong disease. Yeah, the mistake some people think and do, especially in Nigeria, is they feel they're seeing better. But until they start bumping into things, it's peripheral. Your peripheral side vision will start to narrow and narrow. You start bumping into things, and people get used to this until something significant happens. Then they show up. At that point, we throw the kitchen sink on them, hoping that somehow we can prolong vision. Okay. Did I use the wrong word, kitchen sink?
It's okay. You have a question?
I've written.
You have a question? Huh?
Thank you. I was just trying to say that there are a number of pharmaceutical companies that are working on new drugs with different mechanisms of action that we significantly slow the progression of the disease. But those drugs, as far as I'm aware, they've not made it to the market yet. But there's intensive research going on in several companies that I know of. Thank you.
All right, thank you there.
So as far as that is concerned as well, I know you and also Dr. Jacob, you mentioned about the side effects of some of these drugs. One of the good things about the eye is that you have direct access to it. So it's topical, which then gives you the option to actually administer drugs at a much lower rate than would, affect the entire system, right? So why is it that it appears to me the rate of side effects is fairly high? And so what is the dosage in these drugs that you can just apply directly? The dosages are so high that, you have systemic impact?
Well, something like Lumigan, it started out being 0.3, now it's it went down by 1.1 or so. The strength of it, 0.0, whatever one, but it started out 3, okay, and that was causing a lot of redness. That's the one they packaged for eyelash growth, the 3. So the same thing happened with alpha, okay, 0.2%. From there to, it was causing a lot of redness and allergy. But that's what we prescribe now in generic. They give it 0 copay. It went from 0.2 to 0.15. And then from there to 0.01%. So either the pharmaceutical companies are playing games whereby they start with whatever that can work until they lose the pattern. They go to the next level to hold on to the pattern until they are about to lose that pattern. They introduce another one. And so, it comes in 3 different levels. And the alpha P, okay, the copay for some people, 90 days supply is 600 and something. Then when you go to get the brimonidine, the 0. That's the generic 0.2%, $0. But for some reason, the patients don't complain when they don't pay, I guess.
Yeah, and also there's the vascular nature, right, of the eye too. There is still some systemic absorption. So that's why patients with asthma, we may not want to put them on a beta blocker. Even though most of the action's on the surface, they still get some systemic absorption because of their vessels and the vascular nature of the eye too, right? And exactly what Cordelia was saying, some of the strengths, you may be putting a stronger drop on the eye. So you can get some side effects from it. And so that's why we always want to know the history of the patient too before we give them certain drops.
Just a question on screening. I know the American Gastroenterology Society is pushing for lower age for colon cancer screening for the Blacks. Is the American Ophthalmology Association pushing for a lower age for asymptomatic glaucoma screening? Because I heard 30 years, and so obviously this has to come as an annual screening, just because they're presenting with blindness. So
yeah, actually, I had a slide I didn't talk about. That I was surprised that it started at late or mid-20s. Today they tell you how they split it, how often you need to come in. But the biggest factor there is really family history and trauma. Okay? Trauma whereby you were hit. Blunt trauma that pushes the angle. There's a mild damage to the angle, and you will not even know. And that angle will not drain well, and the pressure will always be slightly higher than the other eye. And over time, that pressure will cause damage. So,
okay.
Yeah, I just want to talk about the features when you were explaining the asymmetrical and symmetrical of the optic nerve. So when it is asymmetrical, is it what happens?
Well, that's part of being a suspect for glaucoma. Say you come in, I don't know if you were here when I was describing the optic nerve. The light area in it versus the pink surrounding it. The dense pink area, it's, I call it millions of electrical wire light structured. They take the light impulse to the brain. When we start to lose them on a continuous basis, that's what glaucoma, continuous basis. Okay, yeah. And usually, glaucoma is usually asymmetric. So when you see an optic nerve with 0.6 cup, large area in the center, and the other one is 0.3, they are glaucoma suspect. Even the glaucoma suspect based on optic nerve and their visual field should be normal. If it's abnormal and you can track it with OCT of the optic nerve and realize, yeah, it corresponds. The area that is thin corresponds to the visual field defect. They have glaucoma. And from my own experience, anatomic glaucoma presents first. It takes up to, let's say, 40% of those nerve fiber layers, the electrical wire light structure, to die before that visual field becomes abnormal. But you will see it in OCT. Okay, the test that will analyze the amount, the quantity, and will spread it all out to tell you superior, nasal, inferior, temporal, how much of this nerve fiber layer you have compared to your age. Whether it's green, yellow, borderline, or red. Red is no good, it's glaucoma. If you can now go to the visual field, most times the visual field for those presenting will be normal. And the visual field, the side vision, and then you look at the optic nerve and take it, look, see elongation, that's see whether that optic nerve looks glaucomatous. If it does, you start treatment based on their age. Okay? Someone in their 20s or 30s presenting like that, you better treat. Don't even wait for that visual field to be abnormal.
Okay, so for hereditary, familiar, and some disease conditions that causes, that predisposes to glaucoma, familiar, hereditary, diabetes. What else could cause glaucoma?
Trauma, myopia. The lower the risk goes down with myopia, including diabetes, especially those with diabetic retinopathy. You don't know which one comes first, because all those laser we do, what are they doing? We're killing the peripheral retina to preserve the center. And so you get a visual field that looks like glaucoma. So that's, what else? You said what predisposes? Huh? Race, yeah, race, age, the longer we live.
Just a quick comment on why eye drops, though they look so minute, why it can cause systemic side effects. Yeah, when you take a drug through your mouth, it's absorbed through your gastrointestinal tract, and it goes through the portal vein to the liver, and the liver metabolizes it. So it breaks it down, sorry. But when you take drugs to the eye, it bypasses the liver, and which is called the first past effect, and it goes into the bloodstream. It's like giving IV medication. So because of that, although it's small, it can cause systemic side effects. Now, there's a paper that I published some years ago in the Journal of American Medical Association with timolol. Although you give it topically, enough is absorbed to lower the heart rate. And when we did exercise stress test, you could see reduced heart rate in healthy volunteers.
Yeah, you're right. So people with bradycardia, we don't use it. We try not to. And if you're going to use them, you need to educate them on the punctal occlusion. And maybe use a smaller strength, the 0.25% and not the 0.5%. Yeah. All of them that go through that, and all you need is one drop, by the way. The volume of the eye is 7 microliter. One drop of any of this medication is minimum of 18 microliter. Now you figure. Okay? Some people put in 2 drops. How many they run their face? Okay, so.
My question is, the pharmaceutical companies, it seems like every day they're coming out with something new. And there are so many side effects for this, that, and the other. Whatever happened, especially since we're from the motherland, of holistic, the natural remedies?
Marijuana.
That's Is that it, really?
Yeah.
I
I
mean,
don't
because
prescribe it, but marijuana. And indeed, if I see you, your pressure was 20-something, and you present, there was a patient with that. The pressure was 10. I said, did you take marijuana? How do you know? Okay, marijuana.
Because I just think it's so crazy that we're spending all this money on medication and nothing's holistic. I mean, nothing is natural, and it should be. And the pharmaceuticals that I know, most of your physicians that are in here, there's a lot of money being made by the pharmaceuticals with you pushing their drugs. Whereas because of where we come from, we should be doing what's natural for us.
Nothing national there will control glaucoma, let's be real. If they catch you with marijuana, they jail you 10 years.
Yeah, but now it's legal.
Isn't it? No, yeah. In Africa, in the motherland.
Okay.
In the motherland. Yes.
But it used to be red tea, red, what is it, Robos tea, and all those things that were supposed to be so natural. Why aren't they being used?
I don't know. The science is not there. I don't know. We need all those traditional, what do they call them? To engage more in trying to let us know what they do. Number one, what are the leaves that you go and gather and mix and give somebody to take because they have stomach issue? You alone cannot know it, cannot use it, cannot, so.
It's a very important question.
Yeah.
There's some leaf out there that will prevent optic nerve damage.
Yeah.
Or reduce intraocular pressure. We don't know.
Yeah.
They should have leaves or something like that. Yeah, and just place in your eyes that will alleviate those problems.
I wish we know, and I wish that they call them quote unquote witch doctors, that they can be transparent and let people maybe help them analyze what it is they use and help others. There was one that on COVID, I read, I don't know if it's true, that Chinese took to China and he died there. Okay. That he has this
question. Yes, this is my wife, okay? Very proud of you, and the presentation is out of sight. Like, one question I have is this: I use eye drops, okay? And I noticed that my eyelashes, right? Eyelashes are turning gray. Is that does it come from the eye drops or what?
Well, your eyelashes, then no, you are, you know, because you color your gray, you don't color your eyelashes. You color your gray on your hair. You don't color. What you need is a mascara and color your lashes. Yeah, it's so growing. You know, you want Lumigan. Lumigan is a potent eyelash growth agent. They said if give it 2 weeks, they're gonna look at your eyelashes.
What happens?
So your eyelashes is growing too much. Either you use stuff and cut it down, or you paint it. I'm all proud of it.
Okay. All right. Are you transitioning now?
I am transitioning to.
So which one are we doing now?
My talk. Refractive. I just did the talk of alcohol.
Okay.
This is my talk here. Refractive cataract surgery. So that's my first love, you know, of cataract surgery. I can be there from morning till night. Just give me water. And so let's start. This is cataract for adults. For older, we're not talking about childhood cataract here. Cataract that we need to remove. And it is reported that people 65 and older approximately have cataracts. If you do, great. Tell them I want to remove it early. And that many also have astigmatism, meaning the cornea is shaped more like a football than a basketball. And the range of the astigmatism, and everyone above 40, if you're not nearsighted, have presbyopia. Presbyopia is where your lens used to be, can easily change shape. It will accommodate and see near. And as you age, the ability to easily change that shape and bring things closer to you start to wane. And until your hands stop growing, then you need a magnifier to bring things closer. And it increases with age. So this is part of a slide taken from Johnson & Johnson. They couldn't come. You know, it said they have no money. Is that only one slide? But,
yeah, it looks like
no, that's it. Okay. So bifocal glasses, because they have for elderly. People can never get used to it. They trip on the stairs. They tell you that they just can't close them. And so they are 2.3 times more likely to fall. Greater than 1 in 3 falls is attributed to bifocal glasses. Okay.
This is not my statistic. I got it from J&J. Okay. And 29 million falls, resulting to 800,000 hospitalizations, and greater than 27,000 deaths. The death is higher than from breast cancer, is higher from prostate cancer, is death from those multifocal, bifocal glasses that lead these people to die, to fall. Falling, if you take calls in the emergency room, it's not something to take lightly about the mortality and the disability that it causes. So 1/3 of our elderly who fall will develop post-fall anxiety syndrome. Total cost of fall injuries in the US in 2014 was 31, is that trillion or billion? Billion. Okay. And so eye surgery reduces fall rate by 1/3. And replacing your bifocal glasses with single vision glasses makes a whole lot of difference. And the technology is there. You can either want to all of the refractive error. I hope my motion slide here will work. So I'll leave that, just try that. So we've already spoken about this. So presbyopic correction requires a good quality vision, depth of field, and dysphotopsia. The dysphotopsia, these companies that are making out these premium lenses are conquering it. Okay, I remember the first lens, array lens, that came out, is that 2000? Yeah, around 2000. Okay, some of us were afraid. No, I wasn't afraid. I was giving it they come in, you know, you have cataract. And there's this lens if you wish to have it. And I won't charge you anything because it was free at the time with a real lens. And it was working. And so the data came out, and more companies are in there charging an arm and a leg. So the initial lenses had issue with this photopsia, but they have conquered that too. J&J has other specs that even those bright light at night from the cards filter the violet wavelength that will give you both far, the clear in between. They've given me permission to put those lenses in before the marketing. They haven't started to market it. The intermediate and near, and the night vision better than your own eyes. So, so to maximize visual quality, an intraocular lens must have outstanding optics, precise positioning, and sustained stability. So the baby boomers are more willing to try new treatments than previous generations. They value a healthy lifestyle and have high expectations
for wellness and independence, have higher levels of education, and are more active consumer than previous generation. Possess more than half of all US household wealth. So about 10,000 baby boomers turn 65 every year. So I think we've spoken about this one too. So let me go here to talk about the price. So I take you through a movie, if it works. We are in, say, someone with 14 years of lifespan left. Okay, they calculated how much they will spend in glasses without using any of those premium lenses. It comes out to be around $4,800. Okay, although what they put here for the monofocal toric is way high. Okay, mine is 1,000 an eye, so 2,000 each eye. So, and so you'll be saving a whole lot of money with those toric, the ones that will clean the distance for you. And you use readers, that's 1,000 an eye. And the ones that will make you see far and near, if your cornea is shaped like a basketball and not a football, you don't need astigmatic correction. My own price is 2,000. So 2,000 plus 2,000 is 4,000. That's still lower than what they're giving us as what you spend in your lifetime if you have 14 years left. And if you have the astigmatism, because we need to correct it if you're getting a brand lens. So the lens that will correct far, near, and reshape the cornea for you, change it from being football to basketball. In my price is $2,200 an eye. Still is lower than someone who has 14 years of lives. That's so I am going to now turn over to the magic. I need somebody to help me. Maybe we go back to the, where I go there. Okay. So a normal eye, light comes, enters the cornea, that's the cornea there, through the cornea and passes through the natural lens. That's where it is now. And then it's brought to a focus on your retina, giving you a clear vision. Now, hyperopia or farsightedness occurs when the cornea is too flat or the eye is too short. That light impulse, light ray rather, will be focused behind the eye and giving you a blurry vision. Okay? And for those of you with hyperopia, they are the most satisfied patients with this premium lens because they don't see, depending on the severity of their farsightedness. Some can see far, they can see near, period. And so myopia is nearsighted. So the light will come and rest in front of the retina, okay, and giving you a blurry vision. I don't know if this is moving at all anymore. And then the astigmatism is with the cornea. Things can look funny with astigmatism. Okay, that the cornea
It's shaped like a football. That's it there. Things get blurry. Okay. Presbyopia, we've already spoken about. Again, it will give you blurry vision. Now, cataract. Cataract, depending on, I'm moving it, the severity is going. Okay. The light rays coming in, they're scattered and unfocused. And that depends on the kind of cataract you have and what's causing it. You know, diabetes, steroid will make your lens age earlier. Cataract is an aging of our lens. Just like we age differently, so will our lens. Some will age earlier than others. And if you're on those medication, diabetes, that when your sugar goes up, your lens swells, your sugar comes down, doing this will age that lens earlier. And steroid use will also cause a special kind of cataract. Those are young people cataract, we call them, and they are very problematic. The glares can be so disabling. So what does cataract surgery do? Let me see. Oh, we take out the lens, the cloudy lens, and we'll replace it with an artificial intraocular lens, and bingo, you can see. The other one, let's see, no lens selected. So this is showing you someone who had cataract done. What they just took out is you can't see near, but you can see far. You can't see near the food, all right? So now let's go with, this is dining out. Let's go with Odyssey lens. Bingo, you can see your menu just as good as you can see distant. Okay. Let's go to where you are shopping, day-to-day activity. Okay, and for the Odyssey, the near, the distant, everything is clear for you. Okay, and if you go with monofocal techniques, you can see the near things are not as sharp. And if you go with well, astigmatism, you correct it for far and so forth, things will not be very clear near still, but distance will be sharp. So let's go to nighttime driving. Okay, let's go to Odyssey and take a look. The near, the far, you're on the moon driving. Okay, all right. So let's go with monofocal. Monofocal is you don't have you can't see far and near. The distance you can see, but you can see your windshield well. Okay, and the same thing with if you only correct the astigmatism alone for distance, that's E-hands. Your near will not be as good as your distant. So I believe that's really all I have for cataract surgery. Thank you.
questions?
Thank you, Dr. Bill, and I think both presenters was very informative. But in 2018, I completed my cataract surgery. And after that, I stayed in the doctor's office every other week for 1 year. After that, he said to me, there's a hit and a miss, and you are in this. I was hurt for a surgeon did my cataract surgery. Tell me something like that. Professionally, you should not be enough to tell any patient after a year what they will get. I still have problems with my eyes. At night, the glare is so bright that it's unbearable to drive. So I need to come into this forum today has been enlightening, and I thank you.
Thank you. Thank you. Thank you. Wonderful. Well, that's why we do these things. And that's why those companies need to come out here and interact with our community.
Hi, I had cataract surgery, bullseye, maybe 4 or 5 years ago. And right now I'm having troubles. So I'm wondering, how long does the surgery last before, or do you have to do it?
No, we only do the incisional surgery once. When we do the cataract, we preserve the capsule. No matter how much we polish it, because that's where the lens goes, it's still a lens material. There's still some microscopic lens material there that will try to regenerate. For children, you give them weeks or months. You have to clear that back capsule. But for us, adults, we do a laser in the office. It takes 3 minutes. There's no pain fiber in there. We break the capsule in the center. Has that been done for you?
I had this surgery for one eye, then I drove home, things that same day. Then when I went back after 3 weeks for the other eye to be done, I drove home. And then
they allow you, what do you mean by you drive home? By the way, when you come for cataract surgery, you're not driving yourself back.
Well, I was the only one. I mean, I had to drive.
They didn't ask you, who is taking you home? If you tell them, I am taking myself home, they say, case canceled until you bring somebody.
It was okay, it was great. But the thing I wanted to do is now I'm experiencing cloudiness. So
so the capsule, most likely, if you have not had what we call YAG capsulectomy, you need it because your lens behind where your capsule behind where your lens is sitting is cloudy. And we only do it once. If in rare occasions, we may have to repeat it for those who, what is that thing called? The glycerin material that they make. But yeah, just once. Your lens is there. The lens doesn't cloud. What clouds is where it's sitting, the capsule. And that capsule needs to be broken. And we do this in the office. There is no preparation. There is no post. This one is when you drive yourself back.
Okay, all right. Yeah. So I have to make an appointment. Thank you.
Yes.
Okay. Wow, this has been quite enlightening and really informative here.
So the next topic will be, I guess, after break,
yeah.
we do the red eye.
Okay. Is that it? Yeah.
I have the brochures for the lens, different lens on the table there, and we also have artificial tears. So grab one. But what surprised me the most when J&J gave me this slides was the number of falls associated with bifocal. I said, you know, I've never really thought about it. So now when I talk to you guys in the office, you better get this premium lens so you don't be one of the victims. Okay. Patients frequently encounter patients who complain of a red eye. This slide program provides an approach to differential diagnosis of condition that can cause a red eye. Okay. Helping physicians understand which conditions causing a red eye requires immediate treatment, which may wait a few days and which do not require treatment.
Okay. So all subjective ocular complaints can fall into three basic categories: that of decreased vision, that of pain, and that of redness. And depending on the pain, sometimes the pain can be like a foreign body. In those cases, it might be that they have a foreign body, or maybe they have dry eyes, as we talked about earlier, or something that disrupts the corneal surface. It can be a boring pain or a deep pain, and those patients might have something like a uveitis, inflammation inside of the eye. And so we kind of look at how the vision is, how their pain is, and where the redness is in the eye.
Which one is where the zoom is? Is that this one or this? I don't know if they're seeing us or maybe they're hearing us. If not, that's okay. If it's this one, no, this is not the one.
This is it. This is
it. All right. We're not going to use this one. Okay. Redness of the eyes and lids is caused by three types of problems: mechanical trauma, such as foreign body or abrasion; chemical trauma, such as an acid and alkaline burn; and infection, inflammation, such as a corneal ulcer or uveitis.
And so here we have etiologies of red eye in kind of in order of the urgency. A chemical injury that's very urgent. You want to irrigate, irrigate, irrigate. That's the first thing. You want to irrigate the eye to get that chemical out. And we'll talk a little bit more about that later, but that's the main thing you want to remember. Angle closure glaucoma is also something that needs to be treated urgently. And then you have foreign bodies. If there's actually a foreign body in the eye, uveitis, which is inflammation inside of the eye, and conjunctivitis, ocular surface disease, and then subconjunctival hemorrhage.
So deep, intense, aching pain that is not localized may reflect a large corneal abrasion, scleritis, iritis, or acute glaucoma. Photophobia, meaning light sensitivity, pain when exposed to bright light, is caused by ciliary muscle spasm and indicates problems arising from the anterior segment of the eye, such as corneal abrasion, iritis, and acute angle. A halo seen around the light is caused by corneal edema, seen in acute angle closure and uveitis. Halo vision without pain can also be seen in contact lens wear, overwear, and cataract.
So when we look at red eye, we can look at some of the symptoms that patients are having. If there's mild itching, we talked about dry eyes can be a cause, as well as allergy. Allergy, when we hear itching, when patients come in and say, "Doc, my eyes just itch and I just want to rub them all the time," we think allergy. So that's a common symptom found in patients. Burning sensation, we can think of lid disorders. We can also think of things like tear film disorders, dry eye. And we can also have foreign body sensations, which can come from a foreign body, actual foreign body, or a corneal abrasion. If a patient has a corneal abrasion, they may feel like something in the eye. Also, they don't have it here, but recurrent corneal erosions can also, and that's similar to the young lady asked me about the lid sticking. Sometimes patients have their lid sticking to the eye when they have dry eyes. They wake up and it feels like something in the eye. So that's a recurrent erosion. So there are a few things that can lead to the symptom of a foreign body sensation. If there's localized tenderness, patients
keeps changing.
It's changing on us.
Yeah, you can actually move this without. Not earlier. Okay.
If there's localized tenderness in the lid, sometimes patients will come in with a little bump or just with a tenderness of their lid. Those meibomian glands that I showed you earlier in the dry eye talk, sometimes there can be a blockage and they can become so blocked that it builds up in the gland and you get a little bump. If it becomes tender, sometimes that can be a sign of intense inflammation there. Hordeolum is another gland that's blocked. So those are all signs and all symptoms that we can see in the red eye patient.
So a systematic diagnostic approach to patient with a red eye. I think we've done this. Will help the physician reach a differential diagnosis. Did we do this? Okay, that will include most of the causes of red eye. As with any diagnostic problem, the information obtained from a careful history and examination should direct the approach to management. The redness in a red eye usually comes from dilated conjunctival vessels. The sclera is less vascular, as in the case of pink eye, or rarely torn blood vessels, which may exude bright red blood in a subconjunctival hemorrhage. You won't see the vessels. If you can see the outline of the vessel, it's not a bleed. If the blood covers it, it is blood. I mean, if it's covered with the redness, it is bleeding. The onset of a red eye, that duration and clinical costs should be recorded to help distinguish the causative agent, trauma, chemicals, infection, allergy, or systemic disease?
This.
Oh.
We can use the arrows. Okay.
Okay.
Oh, okay.
Done that one.
So, so in terms of evaluating the patient with the red eye, really a few simple things can help in the diagnosis of red eye. The card you see there is a near card. So if you check the patient's vision for primary care physicians, if you want to check their vision, you're checking their near vision with this card. And so you want to make sure if the patient's over 40 that they put on their readers to read. And then you can kind of assess where their vision is, if their red eye is affecting the vision. Also using this little pin light that the card you can get from Amazon for like $5. And I think the pin light is probably $10 on Amazon as well. It has a blue filter that you can put on the end of it. Using a little fluorescein strip and proparacaine, which is the anesthetic drop, you can put the fluorescein in, use this little pen light with the blue filter, and you can oftentimes see if it's an abrasion or if there's a foreign body, something kind of in the eye, in the cornea, that's causing some of their problems.
And of course, the abrasion will lit up yellow, homogeneous, and then surrounding it will be a clear area. So this is another. Let's move to here. Oh, actually, we didn't do that. Stuff here with this.
We can just move it with this.
Okay. The examination, as Jennifer just stated, Snelling chart at 20 feet should be available in most offices, but a near vision card can be used. For young children, an eye chart using pictures can be used. Patients who wear eyeglasses or contacts lenses should wear them for testing if possible. Remember that a patient over 40 years of age with good distant vision will still need reading glasses for near vision. A red eye with decreased vision should signal a vision-threatening disorder. In general, red eye with no vision loss can usually be treated by family physicians, but red eyes with any vision compromise should be referred where possible to an ophthalmologist. We did that. We did that. We did that. Are we going the wrong way? I think we should go this way. Okay, yeah, go forward and then. Okay. Red eye anatomic stuff. Slide 10. That's it. Okay.
So you want to kind of look from outside in. You want to look at the face, at the nexa, and make sure there are no injuries. The face and orbital areas you want to check. Of course, like in thyroid eye disease, sometimes you can just tell by looking at the patient. You want to check ocular movements. You want to check the lids. You also want to look at the globe and see if you see any signs of trauma. Then, so you want to check all of those things, as well as looking at the conjunctiva, the sclera, the cornea with the slit lamp to see if you see any signs of what might cause a red eye in this patient. The anterior chamber is where we, as ophthalmologists, and I think some the ER physicians as well. I think there's a slit lamp machine in quite a few ERs. Can kind of examine, it's using a slit beam of light to look at the anterior portion of the eye. And we can see if there's inflammation inside of the eye, if there is what we call a uveitis or an iritis. And then, of course, we want to check the intraocular pressure because, as Dr. Udo talked about glaucoma, in general, open angle glaucoma, they may not have any symptoms, but angle closure glaucoma, those patients come in with a red hot eye and their pressure sky high.
So a number of conditions cause redness of the ocular adnesia. Although they may not actually cause the eye itself to become red. These conditions are discussed here because many lid problems are intricately connected to ocular surface disease and infections. Most of these conditions can be easily diagnosed and managed in the office. A cross-section view of the normal eyelid demonstrates an anatomy pertinent to the diseased entities. Anteriorly, note the skin, the muscle, eyelashes, and perifollicular glands.
So this is a picture of a block gland. We talked about the chalazion, the hordeolum. It's basically a blocked gland that you see on the lid. And one of the first treatments we might do for this is the warm compress and the lid wipes that we talked about. Warm compresses to help this gland to become unblocked. Sometimes we are successful. We give the patients maybe 2 to 3 weeks, and sometimes we're not. We tell them to come back in if they still have it. And this can be excised in the office, or sometimes we can use a steroid injection in that area to get that gland to go down. And we have IPL, which is intense pulse light, to help with that as well.
So the meibomian glands drain through small openings on the posterior edge of the eye margin. When obstructed, these glands may produce a tender red swelling in the adjacent lid tissue called the chalazion. So as Jennifer told you that, you know, many of those holes, maybe it wasn't going back, but this.
Talk a little bit about that.
So one compresses for this, we spoke about it. When you see it, hit it with what? One compresses. When you see the drain, it start draining. Some people said, "Hey, doc, it's a pus." No, I said, no, it's not a pus. It's the meibomian secretion that now the hole has opened and is draining. Continue. And we use, okay, this one is reset. Okay, here we go.
So this is a picture of preseptal cellulitis. You can see that it's not just a little bump on the lid, the whole eyelid, the upper and the lower is kind of red and inflamed and swollen. When we see this, we want to make sure the patient has a preseptal cellulitis, not a orbital cellulitis. This can progress to orbital cellulitis if the infection continues. So In a preseptal, if the patient doesn't have proptosis, meaning the eye's not sticking out far from the orbit, and if the visual acuity is fine, the pupils are fine, the motility, that they can move their eye, all four quadrants, if they can move their eye in all four directions. And if their vision is not affected, this is a preseptal cellulitis. But we want to get these patients on systemic antibiotics to treat it before it progresses and it becomes an orbital cellulitis and the optic nerve becomes involved.
So when it becomes cellulitis, cellulitis anterior to the orbital septum, those who know what that means, present as an edema and erythema of the lids. The lids are often tender to the touch. The edema may be so severe that the lids are swollen shut. In cases of anterior periorbital or preseptal cellulitis, the acuity, the pupils, and motility are normal. Okay, let's repeat that. For preseptal cellulitis, inflammation anterior to that septum, the acuity, the pupil, and motility are normal. And there is no proptosis. The eyeball doesn't come out. These cases should be treated with systemic antibiotic and warm compresses. A CT scan should be considered if there are concerns that the orbit is involved, or if the condition fails to respond promptly to antibiotic. Septal cellulitis requires an admission, an IV antibiotic. Otherwise, they lose that eye.
Okay, so blepharitis is very similar to meibomian gland disease. They get debris on the lashes, and the same thing. We use warm compresses. We use artificial tears to alleviate the dry eyes that may come from the meibomian glands not working well. And we can also use ointment around the eyes, and antibiotic ointment, because the flora, they may have an overgrowth of the flora, the normal flora that we see around our eyes. Maybe an overgrowth of staph or an overgrowth of Propionibacterium acnes, or any of the normal flora. So we kind of cut down on that. And we can also give them oral doxycycline, which also helps for those refractory cases.
That is the blepharitis. Okay? Yeah. If you're not sure, just tell them to look down and shine light. And if all the base of the lashes are like sleeve, you wonder for. Okay. Yeah, I think we've done that one. I think we've done this too. Orbital cellulitis, I think we've done. Orbital management. Yeah, I guess we need, yeah, this one are for physicians in-house. They need admission. Just consult whoever the ophthalmologist is on. We're not doing the lacrimal dots.
How's the picture of the orbital?
Let's see what this one is.
That was priest. No, that's
that's orbital. Okay.
So a stye is a block gland of at the base of the lash, and then you have the meibomian glands that I showed you, which are a little bit more posterior to where the lash is on the lid. That can become blocked too, and that's a chalazion. So they're just two different block glands. But yes, and oftentimes this can start because of a blockage of a gland, or maybe they had a mosquito bite and it became inflamed and infected, or and they can end up with this redness and this preseptal cellulitis, which can become advanced, and their lids are so swollen they're almost closed, and the eye can be proptotic, sticking out from the globe, and that can be an orbital, which is really what we don't want as an orbital cellulitis.
Chalazion, you have the skin. Style is not skin, is milky swelling. Which one is this? I think we've done enough on this. So, which one is this? Huh? No, we don't need glaucoma. Yeah. Now we get to the meat of red eye here. Okay. Yeah, we can move on there right away. That's conjunctivitis.
Where did I really
You can
went
go the
far.
other side. The other
That's
side.
going the wrong way.
We don't need bacteria issues.
Wrong.
Oh, okay. Oh, we can.
Yeah, just go out and come back. There.
So red eye, if it's conjunctivitis, major cause of primary conjunctivitis in adults are bacteria, viruses, and allergies. The knowledge of the symptoms, itching, for example, is characteristic of allergies, will assist in making a diagnosis. Bacteria, you're gonna have secretions. And some of them are not, the secretion is not watery. Watery secretion is viral. Okay, bacteria, you will have a colored discharge. Okay, so I think we're done with this. Let's keep moving.
Yeah.
Okay. Oh yeah, this is a bacteria. What's the other one? Viral. This one is viral. Okay. And this is bacteria, most likely gonorrhea. Yeah.
Yeah, a lot of times we can tell bacterial too, because a lot of times patients will wake up with their eyes stuck together. They said, I've had this red eye, and when I get up in the morning, I have to use a warm, wet cloth to get them apart because they have so much discharge. So we think bacteria. Viral, like Dr. Udo said, is more watery. Patients can still have a little sticking together, but it's not like a lot of discharge, although it is highly contagious. So viral, they may have a palpable lymph node. When we check them in the office, their lymph nodes may be swollen. They may have a history of an upper respiratory infection, sore throat, fever. So these are all things that kind of key us into a viral conjunctivitis as to a bacterial. Viral, the virus can remain on the surface for quite some time. So I always tell patients, if you have a viral, you don't want to be going to work with your viral infection, because others at your work may get it. If they touch their eye, touch the desk, one comes behind them, touch the desk, touch their eye, they get it. So it can be, yeah, it can be in anyone. But yes, people who work in daycares might, because kids are, teachers, yep.
Allergic conjunctivitis, a lot of swelling involved and watery discharge. Let's see.
The ones we're showing? Yes, everyone, even for viral, they don't have a hugely red eye all the time. They just may have an irritation of the eye. We may look and see, when we examine them in the office, they can have changes in the inside lid, the lower lid and the upper lid. We can flip their upper lid, and there are things that we can see that will tell us too, based on what we're seeing, looking at follicles versus what we call papillae, different changes in the lid, whether we think it's bacterial or viral or allergic.
So this is hemorrhage. You can see the homogeneous pink there covering the, hemorrhage. Just block it. Yeah. So for hemorrhage, we need help, Dr. For hemorrhage, we look for why they are blood, why are they bleeding? You know, the white part of the eye called the conjunctiva has the thinnest, most fragile blood vessel in the body. And so a combination of using a blood thinners for other blood thinners, maybe aspirin.
So you lost connection.
Of course, the major ones that go by
we don't have internet.
Plavix, warfarin, Eliquis, and Xarelto. Those ones are base gums. But they may probably will not be on it. Okay. And if they're on it, they know what's causing it. But they may be on aspirin, vitamin E, omega acid, Bilabo, whatever they call all of that, a big number of them. They will thin the body. And in the presence of sneezing a lot, rubbing your eyes, itching, sneezing, and coughing. Okay, yes. Those Valsalva maneuver will bust one of the vessels. For a normal person, they will seal right away. But for someone with a blood that is thin, they bleed more. And if they are really on those big guns, their eye can bleed to the point that you will see the conjunctiva hanging out. Yeah. And we don't do anything about it. We just find the cause and tell them if indeed we can go back again. Yeah, and bring the red eye again. Yeah, it's in the file.
Oh, it's in the file.
Yeah. Okay. We just have to find. I think we are probably somewhere. Okay. Yeah. So you treat the symptoms. Cough, itching, you treat them so that, and you advise them and reassure them. So, where is that one?
Oh, you're saying for pink eye or red eye?
No, subconjunctival
hemorrhage. For subconjunctival hemorrhage. You know, you could do either. I think some primary care, most primary care will probably send you to us to take a look at it. But if you have an ophthalmologist or an optometrist, you have an eye care professional that you see, typically, yeah, I would call them first.
So we've done a lot of dry eyes earlier on, right?
Yeah.
So we're gonna skip topical steroid effects. Maybe you touched it? Okay, glaucoma, yeah. Yeah, we don't like primary care, and they will tell you they will not give steroid. Steroid has issues. If the patient will follow up as instructed, there will not be any problem. But you don't want to see a patient a week later with more issue caused by that steroid. Yeah. And even corneal abrasion, when we patch them, I think you spoke about it. You don't patch someone who is on contact lens. And if you see them is corneal abrasion, just give them frequent antibiotic ointment, follow up with us. We can tell whether it's abrasion or whether that abrasion has progressed to corneal ulcer. We see the infiltrate.
Yeah, and sometimes we might use topical steroids in the red eye patient, especially if it's a allergy. Sometimes those patients are treated with antihistamine drops. We have some that are over the counter that you can get, and we can prescribe some antihistamine drops for them. And sometimes that doesn't work, and we have to use a topical steroid to help. So in that case, usually the ophthalmologist can see the patient, treat them, and follow them for any elevated pressure and discuss, the risk of cataract formation. Also with some viral conjunctivitis, they may have corneal changes too, that might require, a steroid, but close management.
I think we are getting close to the end here. So we did this, we did that. We did, are we still going backwards? Oh. These are duplicate slides. Duplicate slides. I think TS deficiency we did. Gee, man. So if you have any question, you let us know, and so we can go have our own lunch.
Yeah. Thank you.
Okay. All right, you have eaten now, so let's ask them questions so that they can also quickly have their own lunch just like everybody else. So anybody?
Thank you so much. Thank you for that awesome lecture. Quickly, between viral and bacterial conjunctivitis, can it start first as viral, progress to a secondary bacterial infection?
Absolutely.
And how do you follow that?
Sure, they can get, but usually if it's viral, again, we'll see changes on the slit lamp exam. And usually viral will start one eye, then progress to the other eye. Maybe a few days later, it gets worse within the first few days before it gets better. But usually we're seeing just, we'll see the viral, it'll go away on its own. So maybe in 2 weeks or so, it might take a while. Sometimes 10 days, sometimes 2 weeks. And so there's not really an antiviral drop that we give them, unless it's something like a herpetic infection, which is the same one that gives you cold sore. But if it doesn't go away and we're seeing a lot of discharge, then we're thinking, okay, maybe not, the patient is getting a bacteria. Usually it's one or the other that we see in the office. Usually they don't switch from one to the other.
My question is about the hodilom and the chalazion.
I'm sorry.
Yeah. So my question is about those conditions whereby the glands, like you mentioned, the meibomian glands, they get clogged. Is there anything that people can do? Like, is there anything that predisposes people to it, and what we can do to make sure that we don't get it, I guess,
Yeah. So there are certain conditions like rosacea that we talked about. Those people are more prone to getting black glands. There are, sometimes we don't know why a person gets it, but they get it. So what you can do is use warm compresses, and that's what we tell patients to do. I have patients who are using warm compresses. They're doing the lid wipes. It does reduce their risk of getting it. Sometimes people get it anyway. So, you know, in terms of anything you can do to never get it, not really, other than, I mean, sometimes the wipes or the warm compresses might help, but to get patients to be compliant with that, if they have a hordeolum or a chalazion, surely they can, they will do it. Other than that, I don't know if Dr. Udo has any, but I can't think of anything else short of that. And you know, just it really doesn't have a lot to do with how well we clean our face or anything like that. It's just those glands get blocked. But other than rosacea, I can't really think of a whole lot of other conditions that, you know, predispose to.
Yeah, sorry, I just have a simple question. What's your take on the over-the-counter anti-redness drops? Because I spent a fortune on this. I'm using Lumify right now. I've gone through a whole bunch of stuff, and
yeah,
it's quite expensive to do those, but they work. I don't know, what's your take on anti-redness solutions?
So Lumify is actually not too bad. I don't recommend that you use it all the time. I mean, it'll last for, I think, 8 to 8 hours or so, or 8 to 12 hours. So I don't have an issue with Lumify. I think it works pretty well. But if you're needing it every day, then there's a reason. So I would prefer you get the dry eye. If it's dry eye, treat it so you're not getting red eye, because you're still getting inflammation on the surface that's coming and going, and that's not the healthiest thing for the surface of your eye. So other red eye drops that say get the red out, like Visine, or those I do not recommend. And the reason I say that is because they have a component in them. Once you stop that drop, if you've been using it a lot, you get a rebound redness. So usually I recommend that if you're going to a wedding and you want to put a drop of Lumify in and your dry eye treatment is not optimal at the present moment, that's okay. But if you're having to use it every day, I would say see your eye care practitioner to get treatment for whatever is causing the redness.
Okay. All right. Okay, any more questions? All right, we're gonna. Okay, so at this point, we are going to transition to listening to some patients for patient experience. Some of these conditions that our ophthalmologists have been talking about, real people actually have been suffering from these and they've been treating them. And so it will be good to hear from the other side of the table, as it were. So you've heard from the physicians, now you're gonna hear from the patients. So I thought we were supposed to have like 3 or 4. Are you coming to, ma'am? All right, so what I'm going to do is, so the patients are over here. So we have, so if I may ask you, quickly introduce yourselves and tell us what your own situation is and how you've been coping, if you will, okay? All right, thank you so much.
Good afternoon, my name is Calvin Fountain. I'm a patient of Dr. Uda. I have glaucoma. I just got cataract surgery a couple of months ago. At this point, I'm coming along pretty well. And Dr. Uda is fantastic. And every day
Thank you. These are my family.
Take a drop. The dry eye. But I'm coming along pretty good. And just, you know, you have to, it's challenging. I'll just say like very challenging or whatever, but you have to stay with it or whatever. And most of the time you'll be okay.
So if you don't mind, challenges, talk a little bit about those challenges and how you're coping with them, because you never know who else could be. I mean, not all of them, but just give a few examples.
The challenge is the drops. I'm taking quite a few drops, and I have other issues as far as medical, and combining all together it's a challenge for me personally.
Sure.
So
but coping well.
But I'm coping with it, and so far everything's going on pretty good, pretty smooth.
Right.
So I'm grateful for that. And I'm grateful for Dr. Udo.
Dr. Udo, yeah, great.
All right. Thank you.
Okay.
My name is Dr. Stewart.
The mic closer, please.
I have a Roman course, but I have surgery 2 years ago. I don't have it. So they will tell myself I have just drop twice a day, morning and night. And I can read very well.
Yeah, he has the multifocal. The multifocal IOL. So yeah, tell them what changes he has done.
And before that time, I've spent a lot of money changing because and buying books because I love reading Bibles. I'm trying to from smaller letters to bigger letters, which now I can read my Bibles, smaller letters. They do my testing and read from my phone, which I wasn't. So I'm very grateful.
Wonderful.
Good afternoon. My name is Carol Spells. First, I want to say that this was the most informative symposium that I've been to in quite a while. At one point, it had me thinking about, I've had just about every eye disease that they've shown. And like I said, at this point, I've had the laser surgery, I'm due to have cataract surgery. And to show you that I'm a lifelong learner, I've brought all of my eye drops with me. And now I'm just finding out that, again, when I was younger, I was on the Lumigan, Comigan, and coming to this symposium allowed me to know that it was the different strengths that the pharmaceutical companies are placing in our eye drops, which is causing us to have to be aware of the differences in the eye drops. So I'm very thankful, and I've been having the same issue with, the changing of the eye drops and making sure that in the morning I'm putting in the right ones. In the evening, before I go to bed, I have to put in the right ones. And it's challenging, but we do what we have to do in order to keep our eyesight. And like I said, I am a glaucoma and patient, and I'm just thankful that I found someone that is knowledgeable and helping me to maintain my eyesight.
Yes. So my name is Clem Okoji. I had acute glaucoma to my left eye. It came as a result of, I do not really know, because I had that lashes after 3 days before I start feeling the pain, driving to Harrisburg. That was the night, the evening my daughter was in labor. So I was at that hospital. The pain was getting intense. I was thinking that, did something get into my eye? you know. Then the following day I came back, I rushed to Dr. Udo. And he said he checked my pressure. I said, wow, you have acute glaucoma. So what kind, what? So the left eye, the pressure was very high. The right was normal. So she did laser that day. You know, I was in the office, she was reducing the pressure, She will do something, I will come out, and then she will tell me, okay, come back again. And we continued until the pain all of a sudden disappeared. So she gave me just the erythromycin ointment. I told her to come back. And so as a follow-up, I think there is a little defect now to that left eye. We haven't really known what is really going on, and there is a little defect. And so I had an acute glaucoma. Thank you.
So I'm beginning to think that these eyes have a mind of their own. The right eye may think, I want a little more sleep when the left eye wakes up. We heard that before. Yeah, that's normal, is that right? The right eye wants to sleep and the left eye wants to wake up. Is that it? That's what I thought I heard before, right? Is that not correct? Oh, the left eye wants to sleep and the right eye wants to. Now, so this case of acute glaucoma in one eye, is that common? Is it?
I got it.
Really?
Can have like one eye and not the other.
Left eye.
It just cleared up and then it's not.
That same day.
Okay.
I have it. That same day.
What are the risk factors?
Okay, go ahead, tell us.
Black cornea, small eye. They usually go like this. Black cornea. Everybody comes in with hyperemia. Before I dilate them, I just take a look here. We can hear you. Give it a microphone.
She has food in her mouth.
Then I've got a little flock of cornea. Some of them have small eyes. The hyperemia, we drink. You see, I said this is your iris. Especially if you start to grow cataract. Cataract is here. When you start to push up this, and you could narrow the pressure will slow. So you see Eskimos and Asians, they all have eyes. But that is really, it's really an anatomic issue.
Sure.
Okay. So what do? We do laser peripheral. The hole. To go to the eyes. What that does, fluids will wave from after an APM goes to a chip. Then brings this down. But you know the cure is take out the cataract. Once the cataract leaves, it will never, if you have cataract coming with the fact is not a total fixation. You don't have anything here. This iris is So yeah, that's what it is. And once you have one, try to prevent the other eye from going. Things are very.
Okay, so this is really wonderful because see, as with any ailment, medical ailment or whatever, so we have the specialists who are trained to treat, and then of course we have the patients who have different experiences. So these patients who are here sharing their experiences are actually as important, in fact, if not even, because you never know who is having what experience and stuff like that. Just regular people, oftentimes when you hear a specialist talking, you say, oh, the specialist knows what he or she is doing, so it's different. But when you hear from the experiences of regular people, it also has a significant impact. So we really, really appreciate that these patients have come out and they are sharing their experiences with all of us, right? And in fact, some of the things we're hearing may not be, maybe things that we didn't even know existed, that ordinary people on a regular basis are experiencing. So we really, really do appreciate that. So anything else that you would like, I like your meds, right? And I like the meds. Now you say that the meds, putting the drops in the morning and at night, you seem to, it appears to place some level of difficulty, but in fact you do know that regardless of what ailment you are suffering from, whether you're popping your pills, taking them in the mouth, sometimes it's once a day, sometimes it's twice, sometimes it's 3 times. So, and so it's similar to this, but somehow I get the impression that putting these eye drops, confers some degree of difficulty. Am I correct in that? So why is that? If you don't mind sharing, because it seems to me like, I would say, oh yeah, you woke up, you just pop something in. So why should that be difficult?
It's difficult for me because I'm still, after years of putting eye drops in, I could be laying in bed and I'm trying to put them in, and all of a sudden I blink and all the medicine comes out and it's running down my face. I think I need instructions on how to put my eye drops in.
Anything?
Yes.
Okay.
So I agree. I have patients who have difficulty getting the drops in too. And some patients have arthritis and it's hard for them to hold that little bottle and put the drop in. So some companies will make a device that you put on the eye, and I'm not sure which company makes it, but it's a device, and you can put your drop in that device, lean back and just squeeze, and it'll go right on the eye. Some people like that and some don't. But I ask patients to either get in a recliner or in something where their head is back.
Yes.
And then just, even if they put it in near the inner portion of the eye, near the nose, but in the eye, they can drop it there and kind of roll it in, turn their head to the side and it'll go in. Because I know sometimes it is difficult, and my patients sometimes will run out of their drops before time because they miss and they're trying again and they miss. So, or have someone help you, to put them in for you. But yeah, it can be a little challenging.
That makes a whole lot more sense now, because as we age, the body changes in terms of, the motor neurons and muscles, and they change. And so things that you would have been able to do as a younger person easily can become a little bit of a challenge. So I can definitely see that you're trying to point a drop into your eyes. Unless you have steady hands, that can be a challenge. Yes. I see that. And it's good that some companies are also thinking about, because these are all issues.
Right. And I know.
Yeah. And this is part of why we want to hear from the patients, because then they could present opportunities for additional, products or whatever to be made. Because ultimately, what you want to do is, in fact, in multi-dosing, if you can even call it that, you can accidentally overdose, right? So you put in the first drop, you don't know how much of it went in, maybe 10% of it went in, right? And then you put in the next one, and then maybe 30% of it goes in. You say, well, it's not quite there. You keep going. So you could potentially overdose, right? So, and I'm not saying that's the case here, but I know that this is definitely a problem. You feel, okay, so you feel it even as it is going in.
Right.
There you go.
That also is soothing, especially for dry eye patients.
And
Also for dry eye patients, that is soothing, and also patients who have allergies, when their eyes itch, cool artificial tears, cool towel, cool compress in that case help. Cool, but keeping the tears in the refrigerator.
Okay. And that's why we come to these things, and I like it. That's why we come to these things and we learn. And in fact, I'm sitting over there with Adora, who said to me that she has been practicing direct medicine, but she said something that she didn't know. When you talk about the fall, old people fall, and the rate is having something like that, right? So, see, you learn. So I'm saying this because professionals are learning, regular people are learning, and stuff like that. So this is part of why we do these kinds of events, so that we learn from each other. And that's how you're ultimately going to get a healthier community, right? Yeah.
Placing the eye drops in your eye, I usually try to go dead center, right to the point there. Is that something that you shouldn't do, or should you drop them to the side or the corners? Does it matter?
Doesn't matter, as long as you get them in.
Perfect. Just a comment, when you said the burden, another reason there's a burden, like if we're taking 10 pills, after breakfast, we take the whole 10, we swallow it, we're done. But sometimes the eye doctors, and you should correct me here, will say, you're using these 3 drops in the morning, put them 10 minutes apart. So now it's a job. Because you put this, you're waiting for another 10 minutes, you put another one, you're waiting for another 10 minutes, you put another one, it's a burden. So that's actually the reason why everybody's talking about the drops. It's not just a drop, it's like the timing, within 30 minutes, you're putting 3 different drops, and that's a huge one.
Got it.
Very, yes.
I got it, so.
Yeah, no, I agree. That's exactly what we're finding too. Some companies and even compounding pharmacies will put 2 drops in one. I think Dr. Udo mentioned some of the drops were 2 in 1 or 3 in 1, so the patient can use that 1 drop. And we tell them 5 or 10 minutes apart because we don't want them washing that either of the drops out. They put 1 drop in, close your eyes, leave it some time for it to absorb, and then put the other one in 5 or 10 minutes later, so you're not washing drops out. But you're right, especially for some of the glaucoma drops, they're 3 times a day, or 2 times a day.
Wow, this is really, this is cool. So, all right, so now you're getting some ideas about the challenges of aging, is that right? So aging is good, but it comes with some challenges, right? Is that it? It does come with some challenges. But the thing is, it's really good for us to be learning these things as we go along. And this is wonderful. So go ahead, ma'am.
I have one question. Like I said, I was a school teacher for 32 years and a computer teacher for all of those years. My question is, I came to this symposium with questions about my own issues with my eyes. I think this is something that should be shown to other teachers in the system, because not only is it good for
the adults to know this information, but it's also good for them to know, or to, if they see a student or a child that comes in with some kind of eye disformity, that they can at least refer them like, oh, I think you need to go see the school nurse, or have the school nurse let your parents know you need to go to see an optometrist. So I just would like to know if it's just the eye doctors that we're seeing, or is this information being given to other occupations?
Okay, so if I understood your question, and of course anybody else is welcome, to share their own insights based on their understanding of the question. But the thing here is this, and that's what you're asking is a very important question. And that's why I'm emphasizing the fact that this is really good that we're doing this. So our organization, Association of Nigerian Physicians in the Americas, we do these events for our people exactly for the reason that you just talked about, right? So we focus on different disease areas or things of that nature in hopes that our people will become more enlightened about these things, not only from a treatment standpoint, but also especially from a management standpoint, So your question is this going to be shared in a wider or broader audience?
Yes.
So we don't have that capability. This is part of what we have Zoom going on now, and I don't know whether this is being recorded so that we can then share it more widely. I don't know, but the question you are asking is really one of, it applies not just to eye and the eye issues, but any kind of ailment. And so that's something for us to kind of consider. Where is Osam? This is something for us to kind of consider. So next time, I don't know what disease area we're going to focus on. We may then make a concerted effort to capture that with the goal of certainly disseminating more widely, to sort of address that concern. I don't know if anybody else has any insights or something.
And then 2 years ago, we did the kidney.
My mother's suffering with kidney stones. Now, my whole thing is the fact that she woke me up at 5:30 one morning and asked me to take her to the hospital. Went to the hospital. She had kidney stones in both tubes, and the one that grew to 3.6 centimeters, which was really bothering her, along with about 100 others down there. The doctor blasted them out from her back, blasted that big one out, and then we're talking, and that was in 12. We're talking within the past 2 years, she's got another one that's grown to 3.5. And we've been looking for a kidney stone doctor, a specialist, because the Caucasian one that she had has canceled 2 or 3 of her appointments. First he was sick, then was a Christmas break, was the next time, and we realized that certain people do not care about us, okay? And that's the problem that we have with so many of these people who don't care about us. It's only about, okay, I'm going to wait until she needs another operation that will provide me with the money for my yacht in the Poconos or something, So, as I said, it's just unbelievable how the care is not there for us. And we were given the name of a doctor from Philadelphia all the way to Virginia. Okay, I don't care where the location is. I will drive to Canada if I have the right person for my mother. Okay?
That's right.
And he wasn't the right doctor. Because the kidney doctor really doesn't deal with that portion of the kidney. Everything is so specialized. I mean, it's like, where are our general doctors who do the whole body, who could look at your nose and say, oh, you've got a cold, or you need something done with your eyes, way back when. They've all died off, the majority of them. But what I want to know is just, like, where can I find a kidney doctor who deals with kidney stones?
So you have raised a lot of very important issues, and one that is confronting all of us, which is our people who specialize in the various areas treating us from this practice of medicine. There are many things that go into healing beyond just diagnosis and giving you drugs, right? There are cultural aspects of care that can impact, what the doctor tells you to do, whether or not you're going to do it or not, right? That knowledge could in fact inform the doctor as to what medication they are going to prescribe to you based on certain things they know about your culture and about certain, and I'm not saying this is right or wrong, it's just that they are important and relevant. As a pharmacologist and a pharmaceutical professional for the last who knows how long, I do know we make the drugs for people, but we do know that the drugs don't always do what we want them to do based on certain factors like the ones that I'm talking about. Okay? So what you're saying about where are our people, and I'm hoping that our professionals who are in here are listening to this, because part of our challenge is really people understanding that our people and our community need care. And we just need care, not just from anybody, but from our own people for certain reasons.
Absolutely.
Okay, so if you can respond to that, thank you.
Sorry, your mother has to go through what she went through. Yeah, so I'm a nephrologist by training, and before I address your issue, one of the biggest problems we have is that doctors don't listen to each other. Everybody focuses on that little part that they are taking care of. Let me give you an instance. I have a patient who is taking certain type of antihypertensive, and the blood pressure physiology mostly happens in the kidney, and the cardiology changes this medication, and the patient comes back, and we have to change it again, and the cardiology changes it again. So obviously they didn't read the notes that we wrote. Now back to your mom. It's often said that if you had kidney stone once, your chance of having it a second time is about 50 to 70% within 5 to 7 years. So, and I've also had patients who are referred to us who clearly need urologic intervention, not nephrology. Nephrology, we use medicines to treat. So, given your mom's situation, I think she needs a urologist, not a nephrologist. Okay. And they also have to find out what is causing the stone. So some people are prone to developing stones faster and more recurrent than others. So we do like a 24-hour urine stone profile. We have to check your diet. We have to give you medicines that decreases your risk of developing stone. But if you really care, I am at Reading Nephrology, and while I may not offer help for anatomical issues regarding the stone, you could at least find out why she's having the stone and probably give you steps to help you to mitigate those problems. And maybe refer you to a urologist who may be more attentive to your problems.
Okay, so just to add a chip here, I'm a geriatric physician. My average age is 89 years old. And why am I saying that? The body is like a car. You're driving an old car, there's going to be a problem every day. You drive a new car, you really can drive to California without servicing that car. So why am I going back there is as we age, the specialists help us, but a lot of times harm us.
if we want to get away from here today, the only take home I'll say is get a good primary physician. That primary physician could be a physician assistant, it could be a nurse practitioner, it could be a physician, and get a good one. It might mean visiting that primary physician every week, every month, so that they will hear about your problems over and over again. And that's why they went to school, to do the triage for you, to figure out, is it a urologist, is it a nephrologist? And one thing we've done in healthcare today, and that's why everybody is dissatisfied, whether it's the physicians, the PAs, the NPs, or the patients, is we've decided to allow Google Medical School to do the job for us. So your primary care should be the one referring you to a specialist and not the other way around. I could tell you I've practiced medicine since 1993, and now my patients, I'll see them. I went to see this cardiologist, this one, and I'll be hearing it for the first time. It should never be that way. I should be the one sending you and deciding who you see. So all I'm pleading with everybody today is let your physician assistant, let your nurse practitioner, let your physician, your primary care doctor be the one to do the triage. And if they do that, trust me, we're not going to run into trouble. Thank you.
Okay. So especially as we are aging, we have to do certain things in order to take good care of ourselves. And those things may not necessarily be what we think, right? You know, let's go to a specialist. Now, listen to what she's saying. Not that a specialist is bad, right? But what you really need is a good what? A good generalist, because the body is the body. You know, you go to somebody who specializes in the eye, and I'm not saying he's bad, but the thing that is ailing you could be coming from other parts of your body, and he or she also needs to sort of be looking at you as a whole. I think that's what you're trying to say, as opposed to that. So there are benefits, and there are times when you need a specialist, but most of the time you don't, because the body works as a system. That system doesn't identify this particular organ and says, okay, well, we're going to depend on you to do this. They're all interdependent. So what's going on over here could affect what's going on over there. That's a good point, you know? So very good. We're all learning. I'm really learning a lot. So other insights, Dr. Udo. I think we are now rounding up.
Yes, we're done. No, we need to.
Yes.
Yeah, I was just going to mention, she asked me about meibomian gland blockage. So all of those things that like women are more prone to having that. I mentioned rosacea, but also older age. When we talk about the geriatric patients, they're more prone to getting it, but we can see it in any age.
Okay.
The next will be a vote of thanks. I think we're done.
Okay. All right. Wow. This has been fantastic, really. This has been fantastic. Now, what I'm going to say to all of us is this. I see, and you know, when we started, we did a little introduction and we saw that while we have healthcare people here, there are also some people who are not healthcare providers, right? And as far as I'm concerned, the knowledge that I have gotten and I'm walking away with didn't just come from the specialists. Okay? The knowledge that I'm walking away with also came from who? Ordinary people. Okay? And so I say that to say that is really one of the reasons why we do these things. That's why the organization organizes events like this to educate our community about different disease areas. And you never know who's going to tell you what's going to keep you alive. You just never know. It could be the doctor. Oftentimes, it's probably the patient in terms of the way they are coping with their ailments. So be on the lookout. We're going to be having additional events like this. And so when we do, we want this room filled, because the reality is we want a healthy community. That's what we're doing this for, right? We're doing this for a healthy community. And those companies that didn't come here or haven't come here, next time we're going to reach out to them. We want them to come and know and hear or see what is going on within our communities. We want them supporting this kind of important knowledge sharing because it helps all of us. We want them to do that, okay? So, and you've made it that much more worthwhile. So for that, clap for yourselves. Okay. All right. So you say you want to do the vote of thanks? All right. So I'm going to invite the Vice Chairman, Dr. Dahosa, to do the vote of thanks. And then we'll be out of here. Dr. Dahosa.
Thank you so much. Thank you so much. We've had like an amazing day coming together and talking about eye diseases. Just as Dr. Lawrence said, there are many reasons why we do this, but you know, transferring information is our main goal, you know, and these events over the past few years has been a biannual. We've been doing it every 2 years. Maybe my own personal challenge to the executive committee is maybe we should think about doing this every year. I think will impact a lot of lives. So I want to personally thank the speakers today, Dr. Udo, Dr. Jacobs, really very enlightening, awesome topics. I do critical care medicine, but I'll tell you, this was of immense benefit. And I'm sure everyone that listened to your lectures feel the same way. Thank you. Thank you so much. I want to thank the executive committee. I want to thank the planners, the organization committee, especially Dr. Udo, who really took this with so much passion and stuff, you know. Thank you so much. I'm very grateful. I want to thank the patients that came to give their own experiences. Oh my goodness, that was really amazing. And we learned from you too. As doctors, we always learn from our patients because one of the things we gain over the years is the act of listening. So we listen to you and we thank you. I want to thank our sponsors. I don't see them around, but you know, I thank them too because they provided some support, you know. So thank you. So we have some certificates to give out, some certificates of appreciation. The first one, of course, goes to Dr. Jennifer Jacobs. Thank you so much. Thank you, thank you, thank you. Is anybody going to capture this? All right. Dr. Udo. Awesome, awesome. Thank you. So the next certificate is going to go to Dr. Cordelia Udo, our indefatigable chair and major speaker. I actually have 3 certificates for you. You're so special. Thank you. Thank you, Dr. Udo. And the next certificate is going to go to our social secretary, Dr. Kelechi Lawrence. He's been, he really kept this place going very lively as usual. Thank you, Dr. Lawrence. Thank you, thank you, thank you, thank you. Thank you, sir. Yeah, you're welcome. And our next certificate is going to go to Dr. Timi Edeki. Dr. Timi Edeki is our founding chair, very invaluable to the running of this organization. Thank you, Dr. Edeki. Okay. And we do have some other certificates, but I don't think they are around today. Dr. Richard Oyewelu, Dr. Odiran Wankwo, Dr. Hazy Adesonya, and Dr. Bibi Adenusi, as well as Dr. Adora. Oh, I'm sorry. Dr. Adora is right here. Thank you, Dr. Adora. Okay, and
yours?
Oh wow, that's okay. They said I have one too.
That's our vice chair who will take over. Come on.
Yes. Thank you, Dr. Udo. Okay. And so, I don't know if Dr. Lawrence has any other thing to say, but we've had a great day. It was an awesome event. We still have some extra food out there if you want to take home. And thank you so much for coming. We appreciate you.
Let's take pictures.
Oh, pictures afterwards too. Yeah.
All right, so we're gonna when we wanna do this. Maybe come in front here, everybody. Everybody, please come in front. You're gonna take picture to.
Oh, maybe over there.
We want to line up behind this. Oh, okay.
No, I'd just like to thank everyone for having me here. I really enjoyed the conference. Thank you, Dr. Udo, and thank all of you. I'd like to thank my husband also.
Thank you, my dear. Thank you. Okay, all right, come on. Don't be afraid. We don't bite. We don't bite. Come over. Come over. Okay, some people may even want to sit, so that we get everybody. Yeah, exactly. So we could do that. Yeah, some people sit down. Okay, sit down. So that we make sure we get everybody.
I can move this table.
Yes, sir. Yes, sir. Go ahead, sir. Okay. All right, go ahead. Yeah. Go ahead. Okay. Come on, man. Okay. All right. You're supposed to join us. Come on. Does she come? Why do you want? Can she come?
Mommy, want to come and sit
Yeah,
down?
please. Okay, she attended. She's one of the attendees.
Okay.
There you go. Right there. Okay, come closer. Come closer. Get closer. Get closer. Closer. Okay, you getting everybody? All right, thank you so much. Your phone there? Is your phone there? Yeah. Okay, she took me to. Okay.
Yes.
That's a new one, right?
Okay, like your mom wants you there.
I know. Oh, yeah.
She knows I don't ever consider myself.
In you for all the help.
Cool. All right. Thank you. Oh, wow. That's wonderful. Okay.
Thank you for coming.
Okay. So,